I have her run a show.
You do? Okay, great. All right, good.
But as I settle in, we'll just get these first people.
Yeah, so that first one is Fauci and Bob doing it for 15 minutes, and then we're going to be going to a pre-tape so we'll have time to get the next speaker. Okay, I'll give Bob is our main person. So,
He has a break. I'll
he'll have a
monitor.
break during the pre-tape here.
Let me see. Julie, he'll be okay for a little bit, but I'll monitor it. But after this first group, what is the change over there?
After the first group, we put a pre-tape that'll air for 15 minutes. So we have to
So do you want like the next people up? Ready?
As soon as Susan comes to dinner, Mike, either before it's lunch or then we start writing.
What is your second?
The first ones are just one-on-one.
We'll get going.
Yeah, at 9:15 we'll have two guests up there with Bob. And we'll have my food. And I will find the drink. Okay, thank you. We were going to go at 8:30. Thanks.
That's my sister's name. That's the one thing she's got going for her. Actually, I'm not a big fan of my sister, actually.
Good to be back.
Yeah, me neither.
Testing 1, 2.
Good morning, welcome. Please be seated. We'll be starting our program in a moment. Sure. Could everyone please be seated? We'll be starting our program in about exactly 1 minute. Hello and welcome, and thank you for joining us today. My name is Sarah Cott, Senior Vice President of Programming at The Hill, and I am delighted to welcome you all here to the 2023 Future of Healthcare Summit. I'd like to thank our sponsors, Novo Nordisk, Consumers for Quality Care, the Healthcare Distribution Alliance, and the PAN Foundation for their support of today's event. We're convening this morning at a pivotal time in healthcare. We're seeing exciting new opportunities for innovation. The Inflation Reduction Act is kicking in and aims to lower drug prices as Congress continues to think through additional pricing measures. In addition, the pandemic emergency protections have expired, leaving Americans wondering, what comes next? To help make sense of what's ahead in healthcare, we'll be joined by members of the administration and an exciting lineup of experts and advocates who will discuss advancing access, the pursuit of health equity, and resetting the care paradigm across the United States. But first, a few housekeeping notes. In addition to our audience here in the room, we are also live streaming this event on thehill.com. Please keep your phones on silent for the duration of the program, but we do encourage you to join the conversation on social media. You can follow us on Facebook, Twitter, and Instagram at The Hill Events, and we will be using the hashtag #TheHillHealth. It is now my pleasure to welcome our first guest this morning, Dr. Anthony Fauci, former director of the National Institutes of Allergy and Infectious Disease at the National Institutes of Health. Welcome.
Dr. Fauci, thanks for joining us.
Good to
today.
be with you.
You know, the last time we had you at an event, my colleague Steve Clemens was talking to you, and you were saying, I'm retiring from government service, but I'm not retiring. And I want to move on to the next chapter of my life. What is the next chapter of your life?
Well, some of it is unknown, but some of it, in the broad sense, is I felt at the end of my 54-year tenure at the NIH and 38 years as the director of the Institute, that what could I do to contribute to society in the next several years that I still have a lot of energy and a lot of passion about doing things. And I think one of the most important that I feel I'd like to do is to serve as an inspiration or a model for younger people who want to get involved in science and public service, or those who are already involved, to give them an idea of the kinds of things that can be accomplished. So it really is going to be something to be really serving as a resource through writing, through lecturing, through consulting, perhaps getting involved in an academic center, just more to focus on inspiring the next generation of scientists and public servants, because they really are the hope of our society. And I would thought at my stage, given having done this, having had the privilege and the experience of advising 7 presidents and being in the government service for over half a century, that I'd be particularly positioned to do that. So that's really what I was referring to as the next phase.
You've said, obviously, during the time of COVID was a very intense time, and the intensity hasn't stopped. And you're fine, as you've said, with intense moments, as long as it doesn't last for a long time.
Right.
This has lasted a long time. You've had death threats. Why do you stay in the public eye?
Well, because I mean, that's what I do. You know, I mean, it is me. That's part of my DNA. I've been a public servant all my professional life. And we are dealing really in difficult times. There's a tremendous amount of divisiveness in society these days. You know, and I always try to explain to people that differences and diversity of opinion, politically, ideologically, and otherwise, is in fact healthy for the country, because we're a broad country. We have differences of opinion, differences of backgrounds, differences in culture. So that type of diversity I embrace. What has happened over the last few years has been that diversity of opinion, ideologically and otherwise, has gotten to the point of profound divisiveness, where there is a degree of hostility, the likes of which is almost impenetrable when you're trying to get people together. And I worry about that, and I hope that there are a lot of people out there who also feel similarly to me, that want to step up and do something about it. And by doing something about it, I don't mean to do it in a conflictual way, but to reach out to each other. I mean, the people who are angry and the people who are protesting, they're not all bad. They can't be all bad. There's something there that they have a problem with that hopefully we can meet each other halfway, and that's what I'm going to try and do.
As you know, there were protesters outside today. I mean, do you ever run into them? Do you ever engage them?
Well, I don't go out and decide I'm going to go.
No, maybe they decide.
But put it this way, they engage me.
Yes, yes. And have you had any positive interactions in that, or no?
Well, you know, it's an interesting question, and if I might diverge on it for just a second, because I often get asked, having done this for so many years, in the very, very early years of HIV/AIDS, 40 plus years ago, the activist community, mostly gay activists, were trying to get the attention of the federal authorities, the scientific authorities, and the regulatory authorities, to get them to understand that the standard way we were doing things, with the strict inclusion and exclusion criteria in clinical trials, the very stringent regulatory control over the release of drugs on a compassionate basis, was ill-suited to a disease in which virtually everyone was dying. It wasn't like another drug for hypertension where you have 7 other drugs and you're doing a clinical trial for an additional drug, so it takes 7 years to get it approved. They wanted to really relook at how you approach clinical trials and regulation. And they wanted to be part of the process. They wanted to have input. They wanted a seat at the table. And at first, the scientific and regulatory community were put aback by them because they were activists, and probably some stigmata because they were young gay men. I don't think we could deny that. And then what happened is that they began to be very provocative and iconoclastic and theatrical to get our attention. Once they got my attention, I was listening to what they were saying, and what they were saying was making perfect sense. In fact, I would be doing the same thing if I were in their shoes. And that's when I got together, apropos of your question, and really reached out and brought into the fold and gave them a seat at the table, the gay activists. And the effort for HIV from a scientific, clinical trial, and regulatory standpoint improved greatly by doing that. That's very different than what's going on right now, Because what's going on right now is not saying, let me get your attention, I want to explain to you what our side is. It's just attacking people in a very, very hostile way. There's a major difference between those two. One was trying to talk in a reasonable way about what can make things better, and the other is just trying to tear everything down. I mean, I don't see anything out there that's productive in my mind.
Well, speaking of the things that are out there, and I wanted to, we're in 2023, we're heading into the 2024 presidential season, which has already really started. RFK Jr. has not ruled out, if he were president, to prosecute you. Ron DeSantis has used you in campaign ads using AI, so it appears that you are hugging Donald Trump.
Oh, that was wonderful. I really like that.
Are you worried about the country going into next year?
I worry about the country a lot because what we're seeing, and I think anybody who just takes a deep breath and looks at what's going on, that we are in an arena, an era of what I call the normalization of untruths. There are so many misrepresentations and distortions of reality and conspiracy theory that it almost becomes normalized. That, at a time when someone would say something completely outlandish or egregiously untrue and proven multiple times to be untrue, that person would be shamed, and then the society in general would sort of put that person aside. Now, it is so common for things to be said so easily that are totally and egregiously untrue. I mean, proven by facts and by data to be untrue. And when it happens so often, society kind of says, they throw their hands up and they say, well, that's just the new normal. We should not accept that as the new normal, because when facts are no longer accepted as facts, when distortions occur, and when reality is distorted, that will undermine the foundations of the social order and of our democracy. And history has shown us that. Turn the clock back to Europe in the mid-1930s, when that kind of propaganda against certain classes of people made people who were otherwise normally good people do horrible things. So I do worry about that. I think that there is a danger to our democracy if we accept glibly untruths.
Did Donald Trump play a role in that?
Well, I don't want to be saying anything disparaging about any individual, but it is very clear that there was a distortion of truth when the president was the president from the first day. This is the largest crowd in the history of inauguration. It wasn't, and the press secretary gets up and bangs the podium and says it was the best, the largest crowd. I mean, that was kind of a signal out there that, hey, it's okay to completely distort the truth.
The Biden administration any day now is expected to release a report on the origins of COVID. This was mandated by Congress. Different agencies think different things. Where do you think it came
I think
from?
we don't know. And I think we have to keep an open mind.
Will we ever know?
We might not ever know. We might not ever know. But certainly you want to keep an open mind and look at the data and the evidence. What's disturbing is that if you look at the tweetosphere, things are said as if they're facts when they're not.
Do you look at that a lot?
Well, I get it. My staff, my former staff used to put it in front of me.
Right.
But because someone says something that's not true and tweets it, and then somebody else tweets it, and somebody else tweets it, when you're on the fifth tweet, it isn't any further more true than it was on the first tweet. But it appears that the number of tweets makes it more true. Like, what?
No, that's okay. Now, looking at the future of healthcare, we had a massive healthcare challenge with COVID. The pandemic is now officially over. There's been a lot of Monday morning quarterbacking, as you know. You've said the government and you made some missteps. I talked to a lawmaker who was briefed by intelligence officials, and he said, we're going to go back to normal. This was in spring of 2020 in a few weeks. Okay, it took 3 years. So it was a very odd disease. But at the same time, how did we do? Because on one hand, it was a success. Getting the vaccine was unbelievable in unbelievable amount of time. At the same time, we've had so much polarization, the culture wars. What do we learn from that?
Well, there are a number of lessons. I tend to put it into two general buckets, the scientific bucket and the public health bucket. From the scientific standpoint, we did spectacularly well. I mean, the idea of going from a recognition of the sequence of a virus on January 9th or 10th, and 11 months later to have more than one vaccine that's 94 to 95% effective going into the arms of individuals is beyond unprecedented. I mean, if you had asked me, could that have been done when I was a resident or when I was in medical school, I would have laughed and told you, you're absolutely crazy, that'll never be done. And it was done. That was a resounding success. The lesson there is continue the sustained support in basic and clinical biomedical research that got us there. The other bucket is the public health bucket. And that's a complicated bucket because it has to do with real on-the-ground preparedness, communication, interrelationship, surveillance, sharing of information, and a country pulling together. So we thought we were really very well prepared. The world, not just blaming the United States at all, but the world thought that we were really very well prepared from a public health standpoint. And we weren't. This was a very formidable virus that kept on fooling us. The first time that we had a virus within the same outbreak to have multiple variants. The first time that we had a virus of respiratory nature that 50 to 60% of the transmission was from someone who had no symptoms at all, which fooled us about whether we should be wearing masks or not in the beginning, because we did not know that you could be sitting down next to someone who was perfectly well, and just by that person speaking, they would transmit it to you. All those things we didn't know. But the thing
But on the mask, I mean, that was also because we needed to keep the masks for healthcare professionals.
There were 2 or 3 reasons why we weren't recommending masks in the beginning. One, there was a shortage. We didn't want to take them away from the people who needed them, the healthcare providers.
Should you have been more upfront with the American public on that, though?
Yeah, we were pretty, I'm looking at Jerome. Yeah, we were very upfront. We actually said that's the reason why.
Okay.
I mean, we weren't fooling anybody. There wasn't any data to indicate that outside of the healthcare setting, it actually worked. And we were completely unaware at the time of the fact that asymptomatic people readily spread it. And then as soon as we found out to the contrary, then we said, wait a minute, we really gotta wear masks. But the interesting thing that I think was the most devastating negative impact was the profound divisiveness in our country. We were fighting a war with a virus. The virus was the common enemy, and we seemed to be spending more energy fighting with each other than we were fighting with the virus. That has to not ever happen again if we ever get a pandemic. We've got to pull together as a nation.
But if we have another pandemic, and Mitch McConnell, who, as you know, he suffered from polio, and one of the things he said that surprised him, and surprised me too, is that we all wanted a vaccine, or I thought most people wanted a vaccine, and then when we had a vaccine, McConnell said he was really surprised that a lot of people said, I don't want that. Did that surprise you?
Yeah, I mean, the whole anti-vax movement is not only surprising, it's very disturbing. If you look at the data, I mean, you're not asking anybody to love you or agree with everything you do, but just look at data. The curve of people who have either hospitalized or died of COVID, who are unvaccinated, the curve is like that. The curve of people who've been vaccinated, what is the curve of hospitalization and deaths? It's like that. It's profoundly different. It doesn't matter whether you're far left, far right, in the middle, those data don't change. Vaccines save lives, and vaccines do not kill you.
Last question, because we're running out of time. If you had a magic wand, you've obviously, as you mentioned, you've been a public servant for more than 50 years. If you had a magic wand for the healthcare system, what would you fix?
I would make it uniform so that there's equal access for the healthcare for everyone and anybody, for the individuals who are economically, remove the disparities among minorities. Why do brown and black people have social determinants of health so that when they get infected, they have a much greater likelihood of getting hospitalized or dying? That has got to be eliminated. That's what I would do.
Please thank Dr. Fauci. I really appreciate it. Hey, great job. Great job.
Joining us virtually is Tom Vilsack, the Agriculture Secretary, to talk about the connection between good nutrition and health. He spoke to our Editor-in-Chief, Bob Cusack, a short while ago.
Secretary Vilsack, thanks for joining us today.
Happy to be with you.
Well, the first question I want to ask you is that you served the entire 8 years in the Obama administration in the position you now hold. What did you learn for this second go-round?
I think the importance of moving quickly to build on the foundation that was laid during the Obama administration to expand on nutrition opportunities and nutrition security. I think I learned that we focused a great deal on food insecurity during the Obama administration. We also talked about nutrition, but we didn't link the two. And I think what we've done in the Biden administration is we acknowledge and recognize that you can be fed, but not necessarily well-fed. And it's going to be important for us in terms of our nutrition assistance programs to not only advance the notion of food security, but also nutrition security. And we've outlined very clearly the components of nutrition security: meaningful benefits for people, the ability to access affordable, healthy foods for everyone, the ability to translate dietary science into language that people can understand and actually apply in day-to-day life, and also making sure that we do this with an equity lens to make sure that we're not leaving anybody behind as we try to deal with the various nutrition programs at USDA.
I used to cover healthcare, and some people may be tuning in and saying, well, wait a minute, what is the Department of Agriculture doing here? This is not FDA, this is not CMS, not NIH. But obviously, nutrition is a huge part of healthcare and making sure that you're healthy of what you're eating. Can you talk about the importance of nutrition to healthcare?
Absolutely. In each one of our nutrition programs, let me start with SNAP, for example. We know that when we looked at the Thrifty Food Pan and revised that and allowed for higher benefits to families, we knew that that would help ensure that those families could continue to buy healthy foods by the end of the month. Pretty good statistics that indicate that when the SNAP benefits run out, that folks have to make decisions that may not be in their best long-term health interests in terms of the foods that they buy. So the extent to which you have a meaningful benefit with SNAP, the ability to access healthy foods with your SNAP card, obviously results in better outcomes, particularly for children. That's also true, obviously, of the WIC program, to the extent that we established a more focus on fruits and vegetables, a bonus program that provided families with the ability to buy a bit more fruits and vegetables. Obviously, our school meal program, where we're transitioning back to the rules as they were in place before COVID. We know from research that it is the healthiest meal that youngsters can receive, oftentimes from the school. And obviously the importance of school breakfast in terms of early learning opportunities during the day. So you combine all of that, and what you see is essentially our nutrition programs are a critical component. I think we're going to get more precise over time. We're going to do more research in terms of understanding people's basic makeup and figuring out ways in which their diet can be tailored or precisely managed and engineered to their particular health circumstances and conditions. We're excited about the Cancer Moonshot and our role in that Cancer Moonshot in terms of preventing chronic diseases by focusing on precision nutrition and doing research in a virtual center that we established focused on trying to figure out how do you match the genetics of a particular individual, their ability perhaps, or the fact that they may be more prone to an injury, to a disease, and how do you then use nutrition and tailor that nutrition to minimize the consequences and impact of that disease and try to minimize the risk of contracting that disease. So there's a lot of opportunity here, a lot of research, and a lot, I think, that we already know of a direct link between food security, nutrition security, and the nutrition programs that we administer at USDA.
Well, Mr. Secretary, you mentioned COVID. Can you talk a little bit about what what the administration learned on nutrition and healthcare during COVID, and what are the obstacles that remain? Obviously, there's still some supply chain issues in various industries.
I'd say a couple key messages. One, we learned that access to universal free school meals was a fairly popular opportunity that was utilized during COVID, to the point now where states are making the decision themselves to avail and to provide resources to expand access. We saw increased participation in our school meal program, and as I said earlier, it's the healthiest meal that many children will consume in a day. So to the extent that you expand access to that program, that's pretty doggone important. I think we also learned that we needed to make our programs more conveniently available. So on our WIC program and also on our SNAP program, we've seen an expansion of online shopping opportunities so that people can better utilize the opportunity to use these nutrition programs to access the right kinds of foods. They may have transportation issues, they may have more difficulty getting, they may not have access to a full-scale grocery store to the extent that they can do shopping online and it could be delivered to their home. That's obviously a way in which we can continue to expand access to nutritious foods. More to do there, no question. There's certainly more to do in terms of healthy food financing initiative, which is designed to provide resources to try to address this issue of food deserts. I do think it's incumbent on the grocer association and industry to ask themselves as an industry, not as individual grocers or individual stores, but as an industry, what are we doing and why is it that we have areas of this country where there simply is not access to a full-scale grocery store? What are the barriers? What are the impediments? And what is government's role? What is the private sector's role in trying to eliminate the notion of food deserts? It seems to me that we ought to be able to figure this out. We currently at USDA provide some grant monies and resources, and that's fine, but it's sort of hit and miss. It's one community at a time. What I would hope we would be able to do, what the industry ought to be thinking about doing, is creating a real commitment to eliminating food deserts as an industry. It's in the Grocery Association's long-term best interest to have more grocery stores and to have access to grocery stores and to be able to ensure that families, regardless of their zip code, have access to fruits and vegetables and healthy choices. When they don't have those choices, then we all end up being impacted because healthcare costs go up. We obviously have a fairly significant issue with obesity in this country, especially among our young children. We know that there are serious results with obesity at a young age that carry into it chronic disease in adulthood. That's increased healthcare costs for all of us. We also know the military continues to be deeply concerned about whether or not we have sufficient numbers of young people who are physically able and fit to do the work of defending our country. So it's a national security issue, it's a health issue, it's an equity issue. And I think we at USDA want to work in partnership with those who want to solve this issue of food deserts.
Looking at the food deserts and lack of access to healthy foods, is that more of a problem in rural areas and urban areas, or is it a combination of the two?
It's probably a combination of both. I think most people often think of the issue of food deserts in the context of urban centers, where there may be several miles between where you live and where there may be a full-scale grocery store. There may be a plethora of convenience stores, but the offerings in those convenience stores are very, very limited in terms of fruits and vegetables and healthy foods. And so people often think of it in those terms, but the reality is we have a lot of remote areas in the country today. We have a lot of small towns, maybe there are 500-600 people, where it may be difficult for a full-scale grocery store to be profitable, to be located, but certainly there should be an opportunity for a smaller scale store to be able to make it. And again, that's the industry can identify for us what the barriers are, and then we should figure out ways in which we can remove those barriers. But right now, there's a, the analysis is done on a community by community basis as opposed to sort of a holistic nationwide commitment. If we're going to eliminate hunger in this country, which is certainly a goal that many of us are committed to, we have to address this issue of access, and that requires the industry being very helpful to us in terms of identifying holistically, comprehensively, the challenges they face in locating grocery stores and the various models and sizes of grocery stores that could potentially be profitable with a little bit of help or if barriers are removed. So that's my hope that we are able to encourage the industry to provide us that information and direction.
Well, Mr. Secretary, now that the debt limit showdown is in our rearview mirror, now there's other things to tackle legislatively, and one of them is the Farm Bill, which, as you know, has got to be reauthorized every 5 years. This is usually a bipartisan initiative, but as you know, there are always obstacles on Capitol Hill. This is actually more of a food bill in many ways than a farm bill. Where are the negotiations, and are you confident that a bipartisan bill can be signed by the president later this year?
Well, I think that both the House and the Senate are working, the standing committees are working very hard to get to a point where they can reach consensus within their specific body about what the direction and the focus should be of a farm bill. You're absolutely right. It's misnamed. It's not just a food bill. It's not just a farm bill. It's a conservation bill. It's a rural development bill. It's a research bill. It's a forestry bill. It's an economic opportunity bill. It's a risk management bill. It's a very large bill that really impacts and affects all of rural America in particular. And so there are a lot of interests. Most often the differences are not Republican and Democrat. Most often there are differences in geography or in commodities. But this year, I think we're faced with a circumstance where we're getting a bit of mixed messages, if you will, from the House, and from a standpoint of some of the issues that are important. He wants a bipartisan bill, and I support him in that, and he's working hard to get that. But he's got members in his caucus that have a different view about the Farm Bill, which creates some challenges. Certainly we had a very robust discussion and debate about SNAP during the debt ceiling negotiations and discussions. And from our perspective, that ended that conversation, that put that aside. Decisions were made, deals were made. And from my standpoint, as I like to say, the issue of SNAP is snapped shut.
Right.
But I think there are still some serious issues relative to how far and what we have to do to support our farmers during difficult times. And as you look at the Farm Bill, you always have to understand that you work within a constrained baseline budget, and you have to fit all those requirements and demands within that budget. And that becomes very difficult, especially if people want to add things. If they want to change or increase expenditures in one area, that means you have to basically sacrifice in other areas, or you have to figure out additional ways in which additional income or revenue, if you will, can come into the Farm Bill discussions. Those are always very difficult discussions and negotiations. I'm hopeful. I know there's a deep commitment on the part of the legislative leaders and congressional leaders to do this, but it won't be easy. And the reality is, we have seen from time to time, it takes a little bit longer than people anticipate, but eventually the job gets done, because nobody wants the alternative, which is if the Farm Bill doesn't get reauthorized, we go back to what is called parity. I think farmers probably would be just fine with that, because we would see gigantic increases in commodity costs, but I think consumers would be very, very concerned about it, because you would see very significant increases in food costs, which I don't think anybody wants.
From a big picture standpoint, what do you think the Farm Bill needs to do? You recently told Congress that as far as farmers and livable profits, it wasn't a lot of good news. So how can Congress help?
Well, I think we have a fundamental decision to make, which is, do we want a Farm Bill that benefits a few large-scale production commercial operations, or do we want a Farm Bill that benefits the many and the most? I mean, the reality is we had a record year in farm income in 2022, which is the good news. The bad news is that only 7.5% of farmers, those who sell more than $500,000 in product every year, those folks got 89% of that income. And that left 11% for the other 92.5% of farms, nearly 2 million farms to share. I think we have to look at ways in which we can expand entrepreneurial opportunities for those small and mid-sized farms, so that they don't necessarily have to get big or get out, but they can actually offer opportunities for themselves in the next generation by developing additional income streams that come into that farm. It could be a climate-smart agricultural opportunity that creates the ability to participate in ecosystem service markets and get paid for the environmental result that's occurring on your farm. It could be conversion of agricultural waste into something more valuable so that you create new commodities from that waste, like sustainable aviation fuel. It could be expanding significant local and regional food opportunities where farmers can negotiate directly with a school or an institutional purchaser. It could be reducing their costs by embracing renewable energy through the Renewable Energy for America program, now funded and financed at historic levels because of the Inflation Reduction Act. They could also result in that REC basically utilizing what you don't need on the farm to reduce its reliance on fossil fuels and reduce utility costs for everybody in small towns across the country. Or it could be that we take advantage of the president's challenge to expand competition by building more processing capacity, and those processing facilities that are being built can now be cooperatively owned by farmers so that they benefit not only from production of poultry or protein, beef, pork, whatever, but they also benefit from the processing of it. So basically looking at ways in which we can support that entrepreneurial model so that essentially folks have a choice. If we don't do that, then the choice that Secretary Perdue suggested several years ago was you either have to get big or get out. And I don't think that's a choice that, frankly, anybody in rural America wants.
Well, Secretary Vilsack, you've got a lot of issues on your plate. Thanks for spending some time with us today.
Thank you.
Our next guest is Susan Dentzer, President and CEO of America's Physician Group, in conversation with Julia Manchester, the Hill's national political reporter.
Thank you so much for coming out, everyone, and thank you so much for joining me, Susan. We really appreciate it.
Thanks so much, Julia.
Yeah,
Delighted to be here.
when we were back there, we were talking about, getting back to normal in person. It's great to see a big crowd here today. But, obviously the pandemic is not only impacting events like this and, social interaction, but also primary care. And I'm just curious from your perspective, how did the pandemic impact primary care and where do we go from here?
Well, thank you so much for the question, Julia. I think it'd probably be helpful if I do a quick little short elevator speech about APG. Mm-hmm. So we represent about 360 physician groups that are totally dedicated to value-based healthcare. Translation, they want to be held accountable for cost and quality of healthcare. You would think that would be common among the U.S. healthcare system, but as we know, it's not. It's become more common in recent years, but not as common and consistent as it should be. These range from very large groups. All the groups affiliated, for example, with the Kaiser Permanente health system are our members. We also have names One Medical, Oak Street. We have a number of very small independent practices, names you don't necessarily know, and large regional medical groups like Austin Regional Clinic. Also groups affiliated with some of the major academic medical centers, Mass General, Brigham, and UCLA. So really we're kind of a microcosm of physician groups across the country today, treating a total of about 45 million patients, so significant bunch of people. What our groups found during the pandemic is that the way they are paid, which is on a value basis, as opposed to a volume-driven fee-for-service basis, really made a difference. Mm-hmm. Because if you think about it, if you're a health system and you're floating the boat off of elective surgeries, hips and knees replacement, et cetera, that all went away during the pandemic. And that's the reason we had massive amounts of federal provider relief payments going to keep organizations alive. Our value-based groups still had the money coming in because they are not paid on the basis of volume. They're paid on the basis of taking care of a person, for example, what's known as capitation. And because of that very factor, they could stay open during the pandemic. And some of our members even sent the provider relief funds back to the government because they didn't need them, right? So a lot of our groups were able to stay open. They were already, many of them, doing telehealth. So rather than having to scramble to get going, they kind of flipped the switch to do more and more of it and actually stayed open and in business. Now what we are seeing is what the rest of the country is seeing, which is that surprisingly a lot of people continued to delay care even last year, even as things were opening up. And now everybody is seeing a surge of people back in person into doctors' offices, into hospitals when they need to be there. And as we know, this is up against now a serious set of workforce shortages, for example, particularly for primary care physicians. So we're struggling through that along with the rest of the country, but again, because we're paid on a value basis, essentially we've had several years to really continue to create the infrastructure to provide the best care. And apropos of what we just heard from the Secretary, we're able also, because we're in various alternative payment models, we're able to address people's health-related social needs, like food, like transportation, et cetera, all because we're playing in this value arena.
Yeah, and going back to the healthcare worker shortage, I mean, that just naturally leads to burnout. And I mean, 3 years after 2020, I don't work in healthcare, but I can only imagine how healthcare workers, from doctors to nurses to other staffers, feel right now. So how can we provide that burnout and give healthcare workers the support they need, you know, to essentially not quit?
Well, as we know, burnout is really a multifactorial situation, right? A lot of it is due to just the sheer stress of the work. Certainly during the pandemic, that was the case. Dealing with things like electronic health records, the administrative burden is very difficult on many physicians, and actually antagonism from patients. Maybe surprisingly to people, the degree of antagonism that many healthcare providers now feel from their patients, particularly during the pandemic, but even continuing, also causes a lot of stress. So there are lots of different things that need to be addressed. I think the best single description I've heard is from Christine Sinsky, some of you may know, who's the Vice President of Professional Satisfaction at the AMA, says a lot of this is about relationships. We really have to stop thinking about healthcare as being transactional and start thinking about it as being relationship driven. And we have to think about how we create better relationships between physicians and patients, even modeling physical spaces in a way that contributes to the best, most holistic kind of compassionate healthcare. So it's going to be a big slog to deal with these burnout issues. And as we continue to have these shortages and people are under stress, look at what's going on for nurses now in hospital care. It's very difficult, and I don't think we're going to be out of the woods for a long time.
And you talk about those relationships and being in a physical space, but during COVID, we saw a lot of virtual healthcare. Back there, we were talking about, AI and healthcare, that kind of a thing. Obviously, that space has a lot of opportunity, not only for this industry, but industries across the spectrum. But is there a concern about how that virtual element of a relationship between a doctor and a patient, or something like AI, could impact the relationships between doctors and their caregivers and patients?
Well, to take the two things separately, telehealth, which is really just a tool. It's right. It's a different way of having a visit. And I don't know any clinician who thinks that telehealth is a complete substitute for in-person care. They just don't. Right? It's a good tool. It can be a good interim step. You want to screen a patient who thinks he or she might be ill. You want to get a sense of what's going on, make sure they're directed to the right place. That's a perfectly appropriate use of telehealth. As a complete substitute for most care, no. We're going to still need a fair amount of laying on of hands, right? When it's about information exchange, that can be done virtually if it's about really assessing what's going on. And also back to relationships, creating a bond of trust, right? We're social animals, right? We need to have some time together to have that bond of trust, which is really at the basis of a really productive relationship in healthcare. AI, different story, right? And as we know, human beings make mistakes. Guess what? So do computer systems made by human beings. And so does coding made by human beings, right? So we can do a lot in very judicious ways. Clinical decision support, backstopping decisions that physicians and clinicians are making about care, absolutely appropriate. Do we have to be careful about it? Yes. You have to figure out what kind of data is being inputted into these systems so that you're not inadvertently inputting data that is going to create bias in the system. We know that there are a lot of algorithms out there that are frankly just biased, racially, gender-wise, et cetera. So we got to be really careful about what information systems are trained on, number one. And then also, thinking about how we use it to backstop human decision-making, not replace human decision-making, is really important, because we know that if we actually use it to replace human decision-making, lots of bad things could happen.
As we only have a few minutes left, what do you think the biggest challenge is today facing healthcare, specifically primary care, is?
Well, we've talked about the workforce shortage, which is real, particularly in terms of primary care physicians. I teach at a fourth-year elective at Dartmouth Medical School. Dartmouth is my alma mater. And every year I ask the students, how many in this medical school graduating class are going into primary care? This past year it was one.
Wow.
One person, right? Because the incentives are pulling care providers into specialties, even to this day. We have to fix that. At the same time, we know that primary care doesn't always have to just be delivered by physicians. I'm with America's Physician Groups, and I'm saying this, right? We know we can create teams of primary care professionals, nurse practitioners, registered nurses, MSW social workers, nutritionists, behavioral health experts. So we have to think about how we create effective functioning primary care teams and deliver so-called advanced primary care, which is really at the heart of value-based healthcare. I think we have a long way to go to continue to build these teams, but if we recognize that, we can get there. We're going to have to make the investments in the educational and other infrastructure to get there, but we could get the job done.
It's a multi-step process for sure. Susan Dentzer, thank you so much for joining me today.
Great to be with you. Thank you. Thanks, Ellen.
Please welcome our next two guests who will explore innovations in obesity care. Dr. Angela Fitch is president of the Obesity Medicine Association, and Dr. Kavita Patel, primary care physician at Mary's Center and senior policy advisor at Stanford University. They are joined by our editor-in-chief, Bob Cusack.
Thanks for joining us. I wanted to start a question for both of you. Just a general question, but Angela, we'll start with you. What are the greatest barriers to obesity care right now?
Well, that's a little bit multifactorial, but thank you so much for asking. I do think it is, as Dr. Fauci was here, talking about COVID and HIV and other epidemics that we've dealt with, pandemics we've dealt with. I think, the biggest barrier to care today is actually access to care in two ways. One is the insurance coverage of care, and the second thing is the sheer access, the sheer volume of patients that are seeking care today.
Okay.
And so I think it's complicated by both of those things. It's not just a one and done issue. I'll say the third thing I will say is the stigma and bias. So
Right.
The stigma and bias around accessing care is getting a lot better, much like mental health. 20 years ago when there was a lot of stigma around accessing mental health, that's gotten better, today.
Right.
I think we're where we were with mental health 20 years ago with obesity, right?
Okay.
Like we're still at that stage of people finally trying to, finally feeling confident that they can actually seek care without being discriminated against. And that's where we gotta work to get to.
Kavita, your thoughts on that?
Oh, I think it's not just multifactorial, but part of it when Secretary Vilsack was talking about kind of SNAP and WIC. I mean, we're seeing children now, and the food we're handing them as part of like our supplemental benefits programs are nothing short of criminal. Part of what we have to do in our clinic is actually swap out what is subsidized by the federal government, by taxpayers,
Right.
because it's such high density caloric juices, highly I tell parents, if it's got an ingredient list that you cannot like actually interpret, you should not be putting it in your child's mouth or your mouth. And lo and behold, what we hand people is just packages of these highly processed foods. And then on top of that, we do such a poor job with we have such a blended cultural country, such a global country, and we do zero education in nutrition, and all the nutrition education we give is frankly angled in it's anchored in a very kind of Anglo kind of traditional, foods I never ate as a child because I grew up in an Indian and kind of Hispanic household.
Right.
So they were things my parents would never buy and recipes we could never follow. And so when you start things at that, and then add to that most mothers or fathers are working, don't have the ability to prepare lunches and meals, and have to really depend on the school system, which also depends on those highly processed foods that are subsidized by municipalities, states, and countries, we have set up entire generations at a disadvantage. So that is absolutely something part of our fabric, which is why, I know there's too much to talk about, but it's why I'm frankly incredibly excited that we now have multiple ways of dealing with obesity, which I describe as a chronic. It's just like diabetes, it's just like any condition, heart disease, everything. It's of a similar ilk in its multifactorial nature.
Yet it's not a standard benefit on insurance coverage for Americans today to get access to care. Our clinicians that, I'm with the Obesity Medicine Association, which I'm honored to be president of this year. We are 5,000 clinicians of people who do obesity medicine, take care of patients, for this chronic disease. And yet I have clinicians, reporting to me every day that their bills are getting denied from Blue Cross Blue Shield because they billed for obesity. And that person's plan doesn't cover anything related to obesity because that's cosmetic, or that's something that is seen as being elective type of treatment, not a chronic disease.
Kavita, I remember I used to cover healthcare. In 2004, Medicare labeled obesity as a disease.
Right.
However, there are still massive access issues. What do policymakers need to do, whether that's Congress or the administration, CMS, et cetera?
I think absolutely kind of dealing with the access issue by cutting through. Anybody who's ever tried to access any of the benefits, that even if they're dictated as benefits of your insurance program, whether it's prior authorization or death by thousands of paper cuts, we're the only industry that still depends on facts for everything, which is bananas. But that's so. What we do is make the process, as you know, so onerous and difficult, and so dependent on an individual who, again, has usually 1 to 2 full-time jobs, has a family to take care of, has a ton of other responsibilities, and doesn't speak legalese. So I think that cutting through, whether it's prior authorization or being incredibly clear, part of what Nancy Pelosi's office was really trying to do that I thought was incredibly admirable in one of the recent kind of budget showdowns was to try to get a Medicare navigator benefit in place. And I will tell you, I am board certified. I don't know how many degrees the three of us have between us. Even I sometimes cannot navigate my own health care benefits, and I am probably the most educated person in my household on it.
Yeah.
So having some way to be able to sit down and say, here's what I can and cannot get access to, here are the pharmacies and ways I can get things that are the cheapest and also still offer kind of what my doctor is probably prescribing for me. Those are all the kinds of things that I think we could, as policymakers, support, but we don't. And so we like to kind of point fingers. We'll point fingers at pharma, we'll point fingers at doctors, we'll point fingers here, when the truth is that we created the system that we wanted. And what we've done is created more of a kind of utilization management system where it's so hard to get things that you end up just kind of throwing your hands up and kind of calling it a day. And then the training piece, I think Medicare is the primary driver of residency, fellowships, student training. Still a large funder of a lot of these programs comes from Medicare funds, but we need to probably be a lot more pointed about saying these are some clear competencies, even if you decide to go off and become a cosmetic dermatologist, which is what my sister does, and I wish I could benefit from that locally sometimes, but my sister, who just does like a cash pay practice, benefited from a Medicare training program, but we should have some core competencies that even she is required to do because she did benefit from this access and this training. And so I would love to see nutrition, obesity counseling, mental health training. A lot of these things should be core skills on the provider side We just heard Susan talk about like a primary care crisis. It's all the more reason everybody needs to have some versatility. Your surgeon should understand some of these things, for example.
You both are on the front lines on dealing with patients and patients with obesity, and we were talking before we came on stage about Ozempic and their alternatives or similar type of drugs, and I think a lot of people think, okay, well, we're going to solve this problem with drugs, and the demand is so much. I want Angela, go to you first. Can you tell us what's going on the front lines on this issue of the demand of getting treatment that people think will be the perfect remedy?
Well, and again, we're talking about the advancement of science. As we heard earlier, I mean, science has advanced. Lifestyle interventions, so focus on diet and exercise, which is the basis of all treatment. We all have to do lifestyle interventions every day because the world we live in is not inherently healthy. So all of us, I think, should have access to a dietitian, someone to help us that are going to help us to live healthier in our environment today. Because by living defaultly in our environment, it produces excess adiposity or overweight and obesity, right? We have overweight and obesity, 70% of the population are dealing with this, and it's because we're living naturally in an environment that produces such. And so we all have to have that lifestyle intervention at the basis. So it's important to say, we're not just out here saying we need to treat everybody with medication. But when medication comes around, that now is 10 times as effective as lifestyle intervention. So lifestyle intervention produces on average a 2 to 5% weight loss. Yet we expect it to produce a 20% weight loss, right? But it only produces a 2 to 5% weight loss. That's not because it's bad, it just isn't very good for treating obesity. Right? I mean, it's good for other health conditions, but many of our conditions, hypertension, diabetes, many of them have a lifestyle component. Yet we layer on top of that the science of medication. And our science has come so much further that it should be almost unethical or unconstitutional, or since I'm here in Washington, D.C., I can say that, right? It almost should be something.
That said a lot around here.
But it's almost to be something, to not be offered something that now is 10 times as effective. Right? I mean, you're able to now lose 20% of your weight, which infers a cancer risk reduction. It infers a cardiovascular risk reduction. It infers a lot of different help, for you to live a longer, healthier life. 8 to 10 years of increased life expectancy when we get that 20% weight loss. And we can now get that more often than not with our newer line of pharmaceuticals, with our newer interventions pharmaceutically. And so that's why the demand has gotten so great, is that patients now recognize that their person next to them in their office or their neighbor or someone else, I said, just like with the mental health issues that we had 20 years ago when we had SSRIs come about, which were much more effective and much easier to manage and prescribe and to take from a side effect profile, then more people were taking it, more people were feeling better, more people were accessing the behavioral interventions they needed in therapy. And that's very similar to what we're talking about here. And these medications are just so effective in helping people. We need to do something urgently to try to provide better access to effective treatment, because it really should not be allowed, for people not to have access to that.
Give me your experience with patients who want access to these medications.
Yeah, I work kind of in what's called a federally qualified health center, so the majority of my patients are Medicaid patients. And to be honest, they're probably some of the very few people that don't come in kind of asking for a specific medication, unlike maybe a weight loss clinic or a place like Angela that you ran at the Mass General. I think that most of them they're diabetics, many of them are on insulin, and I kind of said, this is something that can get you off of insulin, off of your other medications, and also have 20% kind of weight loss, et cetera. So these are like the perfect candidates for which the trials were done. They are the right people. And even still, I sometimes have trouble getting access to the medications for a lot of reasons, including just the fact that we're out of many of these medications due to people who are probably not the right candidates to get the medication asking for them. So we end up I spend a lot of my days kind of calling pharmacies, trying to figure out who's got which dose at what time and when can we make sure that a patient doesn't run out of their dosing, especially as we're trying to get them to a maintenance dose. But these drugs are nothing short of miraculous. But I use the same kind of commentary that I do for my diabetic patients on insulin or on any other treatment. I wouldn't deny a diabetic their insulin medication, because that's something that's just a fundamental property of their disease, just like obesity. And then on top of that, what's been remarkable about the drugs, and it's been documented, but it helps turn off that kind of social and emotional like noise that happens with food. So regardless of the different factors that lead to your obesity, the medications have been stunning, but I do tell people, Bob, they're going to be on them the rest of their life. And so I'm an internist, so I primarily see my average patient is in their 40s and 50s.
Right.
So we're talking about a game changer for them, but it's something that I tell them, this isn't something you're going to be on, lose weight or get off your insulin and then go off of. This is a part just like your insulin was. It's part of your chronic, the medications that we use for you. I think that there's a lot of like, because of social media and TikTok and Instagram, I think there are a lot of also people who want to get in to get access to these prescriptions who will come to me, and then when I find that they're not the right candidate, they want to lose 10 pounds, for example, Bob, they're not the right candidate for the particular medications that we currently have, and candidly, I know that there's probably better ways to do that weight loss for different reasons. Then honestly, what they will do is they'll leave my office and they'll usually go into an online. There are numerous companies popping up on a daily basis. They'll sometimes get them those prescriptions. And then I end up inheriting them back when they get the initial prescription. Then they come back and they want to integrate that into their care. And I tell them that that's not what I'm going to do. And so it's very interesting. We've developed kind of a parallel hack around for a large, seemingly large population that might not be the appropriate target for this particular set of therapeutics. But it is a renaissance. The way we're dealing with obesity, I'm hopeful that in my lifetime, just like we've talked about HIV and cancer and genetic therapies, I really do think we're on the precipice of doing something significant. When you look at 40% of adults being obese and then look at children in obesity, something huge that could change the American, just so much about what we do in America, productivity, mental health, so many of the things that we've talked about.
In a couple of minutes, we'll open up to questions. Angela, I want to ask you about legislation that's been introduced, and not many measures in Washington are bipartisan, but the Treat and Reduce Obesity Act has been previously introduced in the House and Senate. Again, has Republican and Democratic co-sponsors. Can you tell us about this bill, and do you think it's going to get done in this Congress?
I hope so, because we've been lobbying for this for over 10 years, I think. I can't remember how long exactly it's been on the books, but it's been a long time, and it's time to do it, right? And we have to, we understand that there are cost implications to treating obesity, but there are also dramatic cost savings, as Dr. Patel mentioned, getting off other medications, having higher productivity, having a higher quality of life, not needing treatments for cardiovascular disease, stroke, other types of diabetes complications, kidney disease, dialysis. All of these things get better when you treat obesity. But we have to do it we just have to do it because we need to do it. It's almost like COVID. We didn't stop and say, well, how much is COVID going to cost us? Can we afford to cover it? No, we didn't stop. We didn't stop and say that because it was an urgent pandemic that was killing people. This is an epidemic. Obesity is an epidemic that is killing people. It's just killing them very slowly. And as Dr. Patel mentioned, I'm an internist as well as a pediatrician, and with 20% of our adolescents and children having obesity now too, it is taking 8 to 10 years off of their life, and we're just allowing it to continue to happen because of the idea that it's going to cost us too much. And I think there are other solutions that we can work on, right, around cost. As far as who does, how do we access treatment? Who should get treatment first? And then also, working with different companies like we did with COVID, to come together and say, hey, how much does it really cost you to make it? Can we figure out a way to, get it at a different price? The VA pays a substantial less amount of money for these medications than my patients do at the pharmacy, right? Because of their negotiating power, et cetera. How can we do that, right? How can we really improve access for everyone?
I want to open for questions. We've got a few minutes left. If you have a question, please raise your hand. Our staff will come around with a handheld, and if you can identify yourself and also keep the question short.
My name is Horace Sheffield from Detroit. We have a clinic in my nonprofit, and we've done a lot of great work. Right now, the Senate Bill 279 in Michigan will allow family nurse or nurse practitioners to practice without having the supervision of a physician. There's only one primary care physician for 7,000 residents in this Detroit. Does your organization support such legislation?
The Obesity Medicine Association? Yes, we have several nurse practitioners. Actually, we have a large portion of our membership is nurse practitioners. We are not limited to physicians only. We have dietitians, psychologists, the whole multifactorial team of caregivers that are important to increase access to all types of treatment, including primary care as well as obesity care, which would fit into primary care as well.
Kavita, as far as the trends, you talked about kids, and it's hard to change patterns, of course, when you're getting unhealthy foods. Where the obesity problem affects everybody, I believe it affects over 100 million people in this country, but looking at the data, is it more with low-income populations, rural, urban? Can you give us a feel of where the problem is the worst?
There's definitely disparities where there are higher burdens of obesity in deserts, food deserts, kind of deserts as the gentleman from Michigan was talking about, where you actually don't even have access to care, and then certainly kind of racial and ethnic lines. And we see it with gender as well. We see like higher rates in women in certain age. A lot of that, I think, Bob, is again going back to the way we have kind of medicalized everything. We won't do anything until someone's kind of in a catastrophic situation, and that ends up making all of these disparities much worse. And then on top of that, I think that we've seen something, I'll just kind of say that has aligned with COVID that we've touched on today, is just the themes of, you know, who's not getting care when they need to as a result of kind of 3+ years of like change in access to care due to COVID. And it has been those exact same communities of color, more in many cases, more than not, women more so than men, and then in certain patterns, rural, but I see it in urban settings as well, where you don't have enough care providers, even in an incredibly dense urban setting like Washington, D.C. So I do think it's a combination of all of the above. I will say, there's one good thing that came out of COVID has been the telehealth access. Now,
Right.
Part of the problem has been literacy, though. So my entire population is almost exclusively Spanish speaking, and there are still very poor solutions for that virtual access for usually different languages. You would think that's easier with telephonic access. We have such a shortage of interpreters and providers who speak those languages. So we're also now making those same kind of racial, ethnic, language, education disparities way worse, even though we have this more ironically easy way to access care. So, you know, the problems all stack up. So I'm hoping a lot of these bills and solutions put the literacy into that as part of it, because it has to be, or else you're just going to continue to solve the problem for a very select group.
But also regarding telehealth, which without doubt has exploded, but not everybody has high-speed access, internet access.
Yeah, it's all of, and in fact, it's so funny you say that. So a lot of my patients, they get their access in their workplace because they can access public Wi-Fi. And it's been a godsend that we've been able to cover telehealth visits, because they are the people who are working at Giant on helping put your groceries into sacks, and they'll be able to call me to get a diabetes checkup in the 20-minute window, that they might be able to take a break and access the Wi-Fi through their employer.
Wow.
And so, you know, and then I go to countries like Europe where it's ubiquitous and it's free, and I'm like, why can't we do this in the United States? But I ask that question a lot sometimes, Bob. So.
Well, yeah. Well, we could talk for another hour, but we are out of time. Please thank our two doctors for joining us.
Please welcome Deborah Fraser-Howe, founder of Choose Healthy Life, and Pete Sepp, president of the National Taxpayers Union, and the Hill's general manager, Joe Ruffalo, for a sponsor perspective presented by Novo Nordisk, looking at obesity treatment and access to care.
I heard you have epilepsy. Have you considered shedding a few pounds?
You have psoriasis?
Maybe you should get on a treadmill.
You broke your arm?
You just need to learn self-discipline.
You would never say these things to a friend suffering from a medical condition.
Never.
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 You would not do that. So why would you say it to yourself?
4 out of 10 Americans live with obesity.
4 out of 10.
But most Americans living with obesity don't seek help. due to stigma, shame,
and good old-fashioned fear.
But obesity is a medical condition.
A disease.
Obesity is treatable.
It's treatable.
If you had epilepsy,
Or psoriasis or a broken arm, you get help.
you can get help for obesity.
Because obesity is a disease.
We're all in this together.
So Deborah, Pete, thank you for being with us today. We've had some great discussion this morning. I want to talk a little more about treatment and access to advancements in obesity care. Both of you have worked to advance greater understanding of this. And as far as I can see, this is a bipartisan issue. So how do we fix this? Who has the authority to grant greater access to revolutionary anti-obesity medications for all Americans? I'll start with you.
You know, some people already have access. So the Federal Employees Union, the Federal Employees Healthcare System has access, the Veterans Administration, the Department of Defense, and even some on Medicare. But you know, Joe, with tens of thousands of people aging into Medicare every day in America, all of us, one of them who's already been through that 5 years ago, so all of us are coming onto the system. And the scary thing about this is that we're coming onto the system obese and ill. And the question is, you know, if CMS does not address this, because it's a Medicare issue, and all of these other health programs have access, what do? I mean, they have not yet moved the needle. And the issue is that it is a bipartisan issue. There should be no reason why the needle is not moved. It's already been proven that other healthcare systems can take this on, but it's the will. It's the will. If we don't have the will to do it, it just won't happen. And to have all of these seniors going into the system, it will bankrupt us. There's no question about it.
You know, Deborah mentioned many of the places where this coverage is available. OPM has added coverage for Federal Employee Health Plan, the Veterans Administration, DOD. But one of the big outliers is Medicare. Can you talk a little more, Pete, about why there is this discrepancy with access there?
Sure. I think part of it might have to do with the misperception that the elderly don't get obese, they stop eating. No, that's absolutely not the case. You could have quantifiable fiscal benefits by approving anti-obesity medications for Medicare. I also think there's a failure to think like an actuary here instead of a budget score. Over time, the existence of life-saving drugs as well as life-enhancing drugs can actually reduce the costs of other treatments down the line. And it's not just CMS that needs to get into the act here. We heard about the Treat and Reduce Obesity Act. That hasn't been introduced in this Congress yet. And last year, I believe there were 4 co-sponsors of that bill in the House alone. I mean, we were joking in the green room, Deborah and I, that we're constantly told by congressional staff, well, we can walk and chew gum at the same time. And we both said, no, Congress can't do that. We have to pressure Congress to make this a priority.
So, Deborah, you know, obesity can cause the development of chronic health conditions, particularly in older Americans, high cholesterol, high blood pressure, diabetes. We've seen from your work with Choose Healthy Life that these diseases are disproportionately affecting Black communities.
Yes.
Can you explain what the work you're doing there and how we can improve the overall health outcomes in those communities?
Choose Healthy Life is a network of Black churches across the country. And in these Black churches, we have health navigators. Their responsibility is to link people to care in the community, not just in the church. They go outside the church and to the housing projects and other places and bring people in to link them to care. And in partnership with Quest Diagnostics, we actually are able to offer them a diagnostic tool that tells people where their illnesses are and gives them a report card to take to the doctor so that they can make an informed choice because they have information that they desperately need. A lot of times, and we've had a lot of testimonies from people who had no idea that they had, their PSA was high, their A1C was off, none, until they went and got this diagnostic test and took it to the doctor. And often the doctors have said to them, this is a good thing that you have, and I have to now change your whole makeup for medical care because I didn't realize these things. It's critical that people in the Black community, we died faster than anybody else, and we died more than anybody else. And to go on to, change something for the color of the week. The color of the week is green, so we're changing and looking at this disease or that disease, and not take advantage of the networks that people created during COVID that clearly worked. It turned the Black community around. We are now, we're not okay, but we came out better in the end for the number of deaths. Our deaths slowed where other people's deaths rose. And that's because we use the trusted messengers in our community. People are now seeing the Black church as an entity that can really address their healthcare needs. And we need to keep those kinds of infrastructures going. We weren't the only ones. There were lots of organizations that used what they had to get to where they needed to go, and in public-private partnerships. To destroy those networks now or to walk away from them would be a tragedy.
According to a 2020 study from the Milken Institute, in 2016, the total cost of chronic disease due to obesity was $1.7 trillion, which is about 9.3% of the US GDP. Those are big numbers. So Pete, from your perspective, can you explain more about the fiscal impact of reducing the burden of obesity, and why aren't we investing more in prevention?
Yeah, absolutely. Even the lowest estimates, besides Milken, come in at $500 billion. Only Alzheimer's has an economic impact that big that I've seen in studies. And the fiscal potential here to bend the cost curve of Medicare is dependent on getting more and better prescription drugs into the pipeline, keeping people off operating tables, out of hospital beds, out of doctors' offices, and making sure they get treatments that they need. And the numbers show this. The first 5 months of the COVID vaccine saved Medicare $2.6 billion in reduced hospitalization costs. One study, Journal of Medical Economics, estimates a $23 billion savings to Medicare if AOMs are brought into the picture. These are based on solid research and numbers that go back 20 or 30 years with other types of prescription drugs, especially those for cholesterol and blood pressure. I mean, I'm here today because of that. I'm entering Medicare in 5 years. I'll be able to skip a couple of heart bypasses because I got treatment that my dad didn't.
Well, Deborah, Pete, thank you so much for your time and insights today.
Joe.
Appreciate it.
Very much.
Pleasure.
Welcome to the stage, Dr. Ezekiel Emanuel, Vice Provost for Global Initiatives, Co-Director of the Health Transformation Institute, University of Pennsylvania, with the Hill's Julia Manchester.
Dr. Emanuel, thank you so much for taking some time out of your busy schedule to be with us today. We appreciate it.
My pleasure.
Yeah. So you authored a report with the COVID Crisis Group titled Lessons from the COVID War. I'd like to know what some of those lessons are, and are you satisfied with how we're applying those lessons now?
Well, the short answer to the last question is no. And I think, we're going through our usual habit in America of crisis, respond to the crisis, and then forget it. And this is a conspiracy of the public, politicians, businesses, right? Everyone wants us to forget. Why do they want us to like it in the rearview mirror? Because we want to get back to normal. Politicians don't want it because it's not good for them. Businesses don't want us to focus on it because it wasn't good for business. And that just makes me really worried, and our group really worried about the future, because we're not going to invest in the infrastructure we need to really address the underlying public health issues, build up public health departments throughout the country in a sustainable way, get the data in real time to Atlanta so we can have real-time data analysis the way they do in Israel or Britain or Denmark or Singapore, so you can actually figure out what's going on. Having a very comprehensive monitoring system. The CDC is putting out an RFA for wastewater monitoring, but it's going to be, I think, relatively constrained, and we need a very comprehensive one. Infectious organisms. We also need monitoring of drugs in the wastewater. We need development of next generation, not just vaccines, but a whole series of interventions. And I don't think we've done enough to sustain our market for things like masks, PPE, et cetera. We had this big explosion of innovation and production, but then they're slightly more expensive than what you can import, and we go to the cheap instead of the sustainable in the country. So the short answer is I'm not optimistic about the future, unfortunately, and it looks like we're not going to end up with an assessment of what we did and what we could do better, the way other countries are doing.
And do you think part of that is because it seems, across the world, but particularly here in the US, there seems to be this urgency to move on from COVID, which understandably, but maybe there's not being enough time taken to reflect and to dive into what we did wrong during COVID and what we can improve on. Is that a concern for you?
Yes, it's always, I think it's very characteristic of American responses to crises, and I don't think it's a good thing. And we know that from COVID, that countries that took the lessons of SARS in the early 2000s, Taiwan, Japan, South Korea, all the countries around China, they did better initially, and they did better because they had taken the lessons. They had built their public health infrastructure. They had built a monitoring system of what's coming out of China. And I think those are very important elements of infrastructure. And, I think for the last 40, 50 years, we've underinvested in all sorts of infrastructure, public health infrastructure, pretty close to the top.
Right. And, you talk quite a bit about cancer care and access. How did the pandemic impact that? I had a close friend who had cancer last year, and she was talking about how, it was just a completely different, if she hadn't gotten cancer prior to COVID, it would just have been a different experience.
Well, that is right. So one of the things that COVID did on the bad side is a lot of people didn't want to go in and get screened. And we know that has had an effect. On the good side, it actually led to some innovations, and here I'll advertise for my institution, the University of Pennsylvania. One of the things we did, I had nothing to do with this, so no conflict of interest for me, we actually began giving chemotherapy at home. Now, when I was training 30 years ago, and someone said, you're going to give chemotherapy at home, especially of these pretty toxic drugs that cause a lot of nausea and vomiting and other things, I would have said, you're detached from reality. You need some behavioral health intervention. But now we gave thousands, tens of thousands of courses of chemotherapy at home. And that's, I think, a huge positive innovation that was forced on by COVID. And I think that's really a major improvement going forward. The problem is, as all of you know, we're facing this huge issue of shortage of regular generic drugs now because COVID has exacerbated it because of production lines and things in China and India mainly. And I have a lot of people calling me up, I need cisplatin, my oncologist can't seem to get it, how do I get it?
That's a problem we do actually know how to solve. It is an infrastructure problem. It's also a national security problem. We should not be dependent upon other countries for vital drugs. And it's gotten worse. I mean, when I left government in 2011, my very first op-ed is, we're rationing cancer chemotherapies. That was 2011. We're still doing it 12 years later. We haven't addressed this problem. I'm hoping that the attention that COVID and now the post-COVID moment has focused on this problem will finally get us to move on multiple fronts. We need to really monitor the production quality. We need to onshore or nearshore production. That's going to require some investment, just like the CHIPS Act. And this is important for not just the United States. It turns out these shortages are worldwide because we have all focused on the cheapest production again, instead of resilient production where we can monitor, inspect those facilities, and make sure they're following good manufacturing protocols, et cetera. I'm hoping one of my real is we can actually solve that, address that problem in legislation and solve it so that 10 years we don't come back and say, well, we're still having the shortages requiring us to ration basic things like generic chemotherapies.
So does that process of not relying on outsourcing drugs begin with legislation, or does it begin somewhere else? How do we get on that track?
Given the economics, it's going to have to begin with legislation. So the economics, again, is let's go to the cheapest. So you ask hospitals or you ask oncologists, what do they want to source? They want to source the cheapest. Well, that, the cheapest may not be the best from a quality standpoint, and we can see that. But we also need to have a domestic production. And when you go to certain countries, they are very focused on, buying their own. I was just recently in Japan, and you go through stores there and they say, made in Japan, and they're very proud of it, and they insist this is the highest quality. I think we have to get some, I remember that when I was growing up, we have to get some of that back. We have to have domestic or nearshore production in our allies where we can share. It's very, very, I think, important. And again, we think about this in access to antibiotics. This is also national security. We need those drugs for our soldiers. We need those drugs for their families. If we have to not be dependent on countries where we're having, ongoing tense relationships with, and we don't know where it's going to go. And I think that domestic production also allows us more FDA inspections, more clear access. And by the way, it's not just drug production, it's also the active ingredients, the chemicals we need for many of these need to be onshored.
I think I may know the answer to this question, but do you get the impression that this is a priority for legislators in the administration right now?
Yes, I think the public being so upset about these shortages and the persistence of these shortages. They just weren't a flash in the pan and it was solved, that has made, I think, a lot more attention to this. And I also think this administration, their signature issue in healthcare has been drugs, drug pricing, drug access, and eliminating a lot of the disparities. And I think this fits nicely in that agenda.
Yeah, and we've talked a lot about your concerns with these issues, but what's the number one thing with healthcare that keeps you up at night? Open-ended, I know.
I would say, so the near term is the system. One of the things we saw with COVID is how rickety parts of the system were, how easy it was to overwhelm the system, and we kept talking about we need to flatten the curve so hospitals don't become overwhelmed. Well, the fact is that hospitals today and that part of the system are really teetering economically, burnout from lots of staff, lack of staff in critical areas, and I think it's not going to take much to really create a crisis in the hospital sector, and that actually, I think, the public, politicians, policymakers don't appreciate how tenuous that situation is. 3 years of COVID has really taken any resilience out of that part of the system. And so I think it keeps me up at night that we need a really bad flu season could really knock us off. On the longer term, the real problem, I think, is our system is overly fragmented in every way. We've got this in the last panel was talking about, access for Medicare people versus Medicaid people versus commercially insured versus the VA versus, we should not have that, right? We've got different prices in all those areas. We've got fragmented delivery systems, so the primary care doctor doesn't talk to the specialist, so they don't coordinate, no one's incentivized to do that. And I think we don't have a good way of actually reforming that kind of problem. And that's a long-term problem that is only getting worse, not better. And every solution we add, and here I plead guilty, we added solutions during the ACA. They did a lot of good, right? We got 22 million people insured, et cetera. But we also made the system so much more complicated, and it added another fragmented element to it. And that fragmentation in the end is weighing down on the system. And I don't see people focusing enough on how to solve that problem. We're great, and I think actually we didn't talk about some of the great advances. We have made some serious advances in making parts of the system better. Virtual care, care at home, and things like that. But the whole structure of the system remains totally broken. And we're not making any progress in really trying to fix that. We have too many interest groups who are still making money, but I don't know. If I took a poll here, I'm willing to say that 95% of the people here are not happy with the healthcare system and are frustrated. And you are the privileged in our society. And when that's true, you know there's a serious underlying problem. That underlying problem is what's keeping me up at night on a long-term basis, and something I'm trying to think through. How do we solve that underlying structural problem in a politically feasible way?
That's certainly something to think about. Dr. Ezekiel Emanuel, thank you so much.
Thank you.
Please turn to the monitor to watch the trailer for the documentary film Inhospitable that will be presented by our sponsor, Consumers for Quality Care, tonight at 5 p.m. at the Miracle Theater in Capitol Hill. All are welcome to join the screening.
The cost of healthcare in the United States is simply becoming unaffordable.
Today, what we see is that everyone but the 1% is at risk of financial disaster from even a relatively minor healthcare encounter. Politicians, they're always saying bad pharma, bad insurers, bad device makers, but no one goes after the hospitals. And yet they are the biggest source of price increases in the last decade.
They found tumors in his liver and in his colon.
I started to have trouble with pain in my face and my left ear. I was diagnosed with a very rare cancer.
I've had breast cancer twice, have lung cancer twice. They didn't think I was going to survive. Well, they found another spot on my lung.
They told me, I got 6 months to live.
I don't want to lose my best friend.
If there's a treatment that would help me live a couple years longer, I want that chance.
I don't want to say on my deathbed, crap, I'm dying because they wouldn't let me see the doctor.
We are used to thinking about hospitals a specific way, but this is a big, big business.
Hospital consolidation is the untold story of our rising healthcare costs.
One of the most insidious forms of consolidation is what I call Pac-Man consolidation, where the hospital just goes, a little bit here, a little bit here, and now you're getting bigger.
Well over half the United States are now dominated by a single large health system.
Hospitals, they made $1 trillion last year, and it's going up. And the reason is not because we're getting so much better hospital care. It's because the hospitals have merged and consolidated, and they're demanding higher prices.
Our plan will go up 6 times per month. I finally found doctors who can help me, but I'm going to lose them
I have the most wonderful doctors, and it was hard for me saying goodbye. I cried, but I can't afford to have thousands of dollars in hospital bills.
This is far worse than anything we've ever been through in our life. How do we keep them alive, and where? Our first preference would have been to stay here in Pittsburgh, but that's not an option.
It's hard for people to hold the thought in their head that the hospital that takes care of them is also responsible for raising prices and setting limits on patients' access to healthcare.
We are a network in Atlanta. It's not fair for me, it's not fair for him, it's not fair for our family. We should never have to do that.
My fight to maintain my health care has robbed me of the strength to care for my health.
The vast majority of the hospitals are still considered not-for-profit. Even though they do all of the profit-making things we see them doing today, it just seems wrong.
UPMC is able to reap massive tax benefits and subsidies. They're trying to push other competitors out of the marketplace.
The most essential characteristic of UPMC is our capacity to be opportunistic.
They want to be the Amazon of healthcare.
So what's your salary?
$6 million.
It's a nonprofit hospital paying exorbitant executive pay.
Well, that's your judgment of it.
UPMC does not care.
They shut down this hospital. It was scandalous.
Only in a predominantly black neighborhood would they do something like that.
They're supposed to be a charity. They weren't so charitable in staying in the community that actually needed their services.
The healthcare industry spends more on lobbying than any other industry in the U.S.
Physicians go to school for 10 years or more because of a calling, and then they find out they're not allowed to use it to the advantage of the people that they're trying to help.
To have a system that put people above money, that's what we need to get back to.
We're not just going to lay down and die and let them get away with it.
A lot of times people get mad and say, well, somebody needs to do this. Well, who's the somebody?
I should not be in medical debt to my employer. Roma, get off it. You're not a non-profit.
Just have them look me in the face and say, you don't count. Our money is more important to us.
Can you look me in the eye and tell me that you don't care?
I'm alive today because I am a fighter.
Because of your greed, people are going to die. You have no conscience. You have all lost their souls.
If you think this battle is not real, you need to look at me. I'm telling you right now, it crosses all color lines. I don't care if you're a Democrat or Republican, we are all one.
We should not have to choose between bankruptcy or death.
Now a word from our sponsor, Consumer for Quality Care. Please welcome Sandra Alvarez, the director and producer of the documentary Inhospitable, and Donna Christensen, former U.S. representative from the Virgin Islands, physician and CQC board member.
Hi. Thanks for watching our clip. Yeah, we're going to be screening the film tonight at 5 p.m. at the Miracle Theater, so please come check it out. When we started making this film, we were trying to figure out how to make a story about healthcare consolidation interesting and worth watching for policymakers and just regular folks that don't know anything about it. And I'm a filmmaker. I'm not a healthcare expert. I work on stuff for CNN like the 90s and a show about soccer for Showtime. So I was trying to figure out how to do that, and we knew we had to look at the real impact on patients, communities, and workers. So we were able to film this incredible grassroots movement that was happening in Pittsburgh. And when we started filming, we were talking to the folks there who were coming together and really working together to show the harm of the patients in the community. And they got the attention of their local politicians, of the state politicians, and these state politicians, when we spoke to them, they said the only people that we're hearing from when it comes to hospitals are the lobbyists. That's the only time we ever hear anyone talking about hospitals. So they really kind of talked about the importance of understanding what is happening. And because, when it comes to hospitals, things are so siloed and people are affected and it just feels like this individual thing and you're just suffering with a bill or suffering with, lack of access. It's hard to kind of come together, but the film really shows the ability to come together and the impact that people have, but also the way that they can really make an impact on the politicians that are in charge of their care. So I hope you can come watch the film.
Thank you, Sandra. And thank you so much for this film. I watched it yesterday. It's really important. I hope that everyone will come out this evening. I'm Donna Christensen, retired family physician, recovering congressperson, and board member of CQC. After 9 terms in the U.S. House of Representatives, I'm really happy to be able to continue the work that I was doing as chair of the Congressional Black Caucus's Health Brain Trust through serving on Consumers for Quality Care Board. And we are honored to be one of the sponsors today. CQC is a diverse coalition of former policymakers and coalition members working to ensure that patient voices and experiences are front and center in the healthcare debate. We're happy to see that some of our partners are here today. You've heard from Deborah Fraser-Howes of Choose Healthy Life. You'll hear from Donna Cryer of Global Liver Institute later. Others will join us this evening. As we mark our 6th year, we remain laser-focused on supporting high-quality, affordable healthcare. For us, that means that people can get healthcare they need without having to go into debt or make tough choices about not paying rent or putting food on the table to get that care. Today, it's reported that 41% of adults in this country have some level of healthcare debt, and some of it's really high. Because of this debt, some delay and avoid seeking healthcare that's supposed to be available, especially from our nonprofit hospitals. Yet across this country, we've seen these hospitals, as you've seen in the movie, acting like big businesses with one thing in mind: profits. From mergers and acquisitions that leave longtime patients in the cold, to nonprofit hospitals skirting charity requirements while hounding low-income patients for unpaid bills, hospitals are prioritizing profits over patients. You saw in the trailer for Sandra's incredibly important documentary, Inhospitable. She did an incredible job of exposing some of the dysfunction in our nation's healthcare system and how the big business of nonprofit hospitals impacts real people. We invite you to join us tonight for a screening of the full documentary and a panel discussion with Sandra, with Vicki Arnett, who you've seen in the film, and Frederick Isasi from Families USA. We'll be kicking off at 5 p.m. tonight at the Miracle Theater on 8th Street Southeast. All of the information is on your chairs this morning, and we really look forward to having you join us this evening. Thank you.
Our next panel of guests will discuss healthcare disparities, health equity, and access. Please welcome Dr. Elena Rios from the National Hispanic Medical Association, Donna Cryer from the Global Liver Institute, Kevin Hagan of the PAN Foundation, and Douglas Hoy of the National Community Pharmacist Association. They are joined by the Hill's Bob Cusack.
Hey, thanks for a great panel here. Got a simple question for you. You got to answer each in 2 minutes. What keeps you up at night on healthcare? What are you worried about the future of healthcare? Elena, let's start with you.
Well, I think we learned a lot of lessons from COVID-19, and one of them is that our community has a lot of essential workers that can't go home when there's a pandemic. And, you know, the Latino families, overcrowded, language issues, immigration issues, generational issues, acculturation issues. I think for us, the National Hispanic Medical Association, we're constantly trying to find more Spanish-speaking doctors and Latino doctors or Latino-serving doctors that can talk about the information in a way that is resonant to our communities. And I think that's what really keeps me up at night. It's so important to just get down to basic information to our communities.
Pretty good answer.
So I view things through the lens of a transplant recipient and a leader of an organization responsible for many people in end-stage disease. And so I am preoccupied with making sure fewer people end up needing the level of care that I did, that saved my life and sustains me today. And so as we've talked about all the issues today in prevention, in connecting to primary care, in making sure that we're dealing with whole person care and survivorship, those are all the things really that will keep people well and have fewer people need the catastrophic levels of care that I've received.
Kevin?
I would say, you know, at the PAN Foundation, a lot of our patient population skews slightly older, Medicare age population. And I would say what keeps me up at night really comes down to sort of 3 words. First is access, second is education, and then the third is the need. One, making sure that patients have access to the therapeutics that they need to have their life and quality of life and life extended. I would say, particularly around education, for our Medicare population, there have been some positive changes with the implementation of the Inflation Reduction Act and the Part D Medicare reforms. In 2025, there'll be a $2,000 cap on out-of-pocket costs, and that's great for the patient population. But at the same point, they need to be educated around it because there are some provisions that are involved in that law, like cap and smoothing, that are going to be opt-in provisions. And I think the education of patients as well as physicians and healthcare providers to help assist those patients is going to be really critical moving forward. And then finally, I would say need at the end of the day in terms of patient need. My biggest concern is that when out-of-pocket caps go into effect for our population, the world's going to think, oh, $2,000, anybody can afford that. But we know that's actually not the case. I mean, our own polling shows that 75% of older population actually says that $2,000 is a real stress on them. And that number jumps up to 86% when you look at a Black population and 82% when you look at a Hispanic population. So those are really the 3 things that we're constantly thinking about and I think keeps me up at night.
Doug?
Yeah, thanks, Bob. So for the community pharmacists, we were there, about 20,000 independent community pharmacists in the country, and we were open during the pandemic even when others were not. And so we see patients coming in all the time and have a front row seat into the healthcare system. And I'd say the 3 things that keep our members awake are costs, waste, and access. And so the costs of paying for prescriptions, but also the bureaucracy that's associated with it. And with that comes the waste. There's a tremendous amount of waste in our healthcare system, and our pharmacist members have a front row seat to that. And sometimes they're very frustrated because they can't affect that wasteful spending that they're seeing before their eyes. And the last thing is access, and that has to do with costs and waste as well. And not only the access to the care, but access to the information, access to the services that are out there, but patients may not be aware of them. So those are the three things: cost, waste, access, that keep us awake.
Where are we, Doug, on drug shortages now, post-pandemic?
Yeah, drug shortages are on the increase.
Why is that?
It's a variety of reasons, including some of the access to the active pharmaceutical ingredients, the API, which are mostly offshored. So the vast majority of our API comes from China and India, so we're very reliant on that, and I think we're very vulnerable to that. Another thing that's not talked about a lot is that some generic products, many generic products, have gotten to be so inexpensive, even though some, PBMs will charge a higher price for these inexpensive drugs, but they've gotten to be so inexpensive that some generic manufacturers are getting out of the business and saying, I can't afford to make this. It's not profitable for me to make a $2 bottle of effective medicine. I'm out. And we're seeing more and more shortages, especially with antibiotics, cancer drugs. But it's a big concern, the increase we're seeing in the shortage of drugs. And there really needs to be some thought around how do we prevent that from a sourcing standpoint for the API, but then also reforming the payment model so there's incentives not only for the generic manufacturer, but everyone in the supply chain to make sure these generic products are available.
Kevin, you mentioned the Inflation Reduction Act, and as you know, that was a lot of sausage making. There was a lot of controversy around that legislation. Now there's legal action regarding the Inflation Reduction Act. Number one, do you think that the healthcare provisions will hold up in court? And number two, are you hopeful that Congress, because a lot of Democrats said that was only step one. They obviously wanted to do more, but they couldn't because they didn't have the votes. Just tackle those two things if you can.
So I will never predict what a court is going to do. I've had my share of interactions over the years leading a variety of organizations. So courts to me are always unpredictable. I'm not going to make any predictions around whether they're going to hold up or not. But I would say what's really critically important for us, I mean, you're talking about there needs to be more done, and I would say that from the PAN Foundation perspective, we're always looking at what's in the best interest of our patients. And for us, what really matters is their therapeutic accessible when they need it, and can they afford to do it? So for us, I mean, drug pricing, as you all know, is an incredibly complex web of activities and players. But for us, it really comes down to what's paid by the patient out of pocket at the pharmacy counter. So for us, that's what we've tried to focus on, is what are thoughtful and meaningful reforms and changes that can happen that actually help patients better afford those prescriptions. Particularly because it's not just sort of our population, which tends to skew a little older. We do have a sizable number of patients that are living with rare diseases, and those rare diseases also have higher out-of-pocket costs. So I would say most of our advocacy efforts have really been around trying to figure out what makes that more affordable, which I think is one of the reasons PAN spent so much time and energy really advocating for out-of-pocket caps, as well as things like cap and smoothing. This cap and smoothing provision it can be a game changer for patients because it allows them to basically take their out-of-pocket cost and if they need the drug in January, divide it by 12. So they're not getting this hit at the beginning of the year for out-of-pocket cost. And we think that this is a real opportunity, but it also requires a tremendous amount of education and requires opting in. Which means everyone needs to get familiar in the healthcare system around what that looks like and how patients can access it.
Donna, we were talking a little bit backstage, speaking of education, we're talking about educating patients, and a lot of times, well, most times, you're not educated on a topic unless you are diagnosed with one, or possibly, and then you go online and you worry about things. But what, I wanted you to kind of talk about the education of patients who need organ transplants, and it's not as simple maybe as it may seem. Can you talk about that? I know you're obviously very familiar with this. Yes.
Absolutely. So one, we are in an information climate that is rife with misinformation. And so it's a great privilege to be working with the National Academy of Medicine and WHO and many others to help to solve that, so that anything that we put out as a patient advocacy organization working with medical societies will stick with people, that it's not in the noise of all of this misinformation. So that's a major problem that all of us face and have a responsibility to confront. Around transplantation, many people think that it's just moments and miracles, and it certainly is, but it really is more about prevention, having access to primary care so that you can get a referral to be listed for transplant, to make sure that organs are available. And we've been working with Congress in a very bipartisan way to have reform of the organ procurement system. And CMS has been moving forward with that, and so we're very grateful for the administration standing up really on this issue, that it's sort of the issue of my lifetime, because 20 some years ago when I was first transplanted, we recognized that this was something that needed to happen, and so maybe I can retire now if we can get this done. But also we have issues of availability from living donors as well, which is responsible for a lot of the growth. And we know that there is a Living Donor Protection Act that is being put forward. And so I think that this is in some ways the golden age of innovation and access and hopefully equity in transplantation, if we can make things happen. And it's really the simple blocking and tackling things. It's not, there are so many large challenges that we don't yet know how to solve. In liver disease and in transplantation, we do know how to solve them. We just have to have the will. We need to actually give people hepatitis C cures, as Dr. Collins has come out, and that so many members of Congress, Senator Cassidy is certainly working to help. We need to make sure that people have the obesity medications. NASH is one of the key drivers of transplantation. We need to make sure that they're vaccinated against hepatitis B. I mean, it's a wonderful problem to have, that we know what to do. We just need the will to do it.
We'll be opening up for questions in about 5 minutes or so. And I want to talk to you about, speaking of health equity, Dr. Fauci talked about it earlier. Where are we, and what has worked, and what do you think policymakers should do, whether that's the administration or Congress or states, to improve it, to make, and maybe talk a little bit about progress we have made, but where we need to go?
Yeah, I think the Biden administration has really done a great service to the country by having health equity plans in every agency, every program that the federal government has. So, and there are more focused efforts on health equity than ever before in climate change, for example, just our environments, obesity, the way we live, and language. The Office of Civil Rights is now making it discriminatory for our federal funded hospitals, clinics, medical practices. They have to have language services now. But I think one of the most important things, this is the 5-year reauthorization of the workforce. The workforce shortages in this country are amazing in healthcare. Doctors, nurses, pharmacists, dentists. And one of the biggest things we can do is recognize, and from the Latino perspective, the 2 largest school districts in the country, Los Angeles, 75% of the Los Angeles Unified School District are Hispanic. New York City's school district, over 40%. That's our workforce. Our workforce in this country, we're going to be 1 out of 4 Americans in the next 10 years, Hispanics. And I think we need to stop ignoring our community and give more counseling and mentoring from our organizations like the Hispanic dentists, Hispanic nurses, Hispanic pharmacists, Hispanic medicine, because we're the alumni of the schools of this country that made it because of affirmative action, because of financial aid in the 1960s. We're the first generation of professionals in healthcare, and we should be the deans of the schools. We should be the faculty. We should be on the boards of trustees of these universities. And why aren't we? Because we're just figuring out how to help each other with leadership development. But getting back to policy and your question about health equity, I think the shortage will be changed if we can have more residency slots for more doctors to be trained in this country, and more community-based clinics and the children's hospitals getting their funding, and also that we have more language training, medical Spanish in medicine, nutrition training in this country, and that we have more physicians working together to be a doctor, to want to take care of their patients and not just go by the rules of insurance companies or the rules of the industry in general. And I know that that's happening, but we just need you to know that the National Hispanic Medical Association is very excited about building our organization.
That's a great topic on the workforce issues. We have an aging population. We have Medicare headed for bankruptcy. We've got, especially after COVID, we've had shortages of healthcare practitioners. Anyone else want to join in? Like, what do you think about, Donald, like, where are we going in that issue? Because we need people to take care of this aging population.
Absolutely. I think that Elaine is absolutely right in terms of the virtuous cycle that comes from having more healthcare practitioners at every level, from techs to surgeons, who come from that community. Then you have not only jobs and an economic engine, but you have more people who can deliver in language, culturally concordant care. So it's not just about solving the issue of better health outcomes. That would be good enough, but you've really created a virtuous economic cycle within communities and enriched it with people who understand and can talk and be the translators for their families and explain health issues. So you've really addressed the problem in so many different ways by building up a workforce from the communities, for the communities, and then I want to make sure you underscore this point, and then making sure that those folks are on the boards of the hospitals and are in charge, deans of the schools, and are in charge, because ultimately this is about power and who gets to make the decisions and who sets the agendas. And if more people from the communities are the people who help set the agendas, then the agendas will better reflect the needs of those communities.
Kevin, regarding, go ahead,
real quick, I think
jump in.
that just healthcare jobs, we need to make them, I mean, they've become unglamorous jobs, in my opinion. I mean, you have doctors, which has always been Marcus Welby, ER, tons of doctors. I mean, that's been a very glamorous, and it probably still is, but I think, my son's 20, he's not going into healthcare, he's going into technology. That's the glamour job right now. And I think part of the problem is the payment system that just bogs down and makes it harder for patients. And it just, when a young person sees that, they're like, I don't want to do that. I want something that's more interesting. So I think we have an image problem in all healthcare, and we need to make that, we need to reform that and just show how we're helping patients and that there is a lot of satisfaction. But I know in pharmacy that there's a lot of unglamour, if that's a word, and that needs to be reformed through payment reform.
And your son has no interest in going into healthcare?
No, I've got 2 more kids after him, so we'll see.
Well, I've got 3. They all want to go into healthcare. I have no interest in journalism, so maybe they've seen my hours. Kevin, your thoughts just on that, and also I wanted to touch upon healthcare innovation. You've been in the healthcare field for a long time. What are you kind of excited about? I also want to kind of talk about positive things going forward instead of all negative things.
Yeah, so just in terms of sort of the workforce thing, less specific to PAN, but I was the former CEO of the American Diabetes Association before coming to PAN, and clearly, workforce shortages, there is a massive shortage and has been for many, many years of endocrinologists in the United States. So I think you're spot on in terms of the glamour of it. It's not perceived in the way that I think it was to be in healthcare, 20 years ago. When we were at ADA, we started a fellows program where we intentionally tried to lure people in to specializing in diabetes. So, I think there are definitely challenges on that front. In terms of innovation, it's interesting. There's so much going on in healthcare. I mean, from just therapeutics with gene cell therapy or gene therapy and cellular therapy. But there's also, we have, everybody's been hearing about AI lately, and, now there's starting to be commentary around how AI is getting used in medical practices and healthcare in general, and making determinations about prior authorizations. So I think there's an interesting positive horizon out there, particularly around technology and the use of some of these burgeoning technologies. But I also want to be reasonable and cautious that we do train and have specialized healthcare professionals for a reason, and I think the balance of those tools with the expertise of people who have deeply studied this is going to be critically important going forward.
Got a few minutes left. Let's open it up to questions. If you can raise your hand, and staffers will come to you with a handheld mic, and if you can identify yourself.
Hi, thank you so much for talking. I'm Dr. Ashley Tucker. I'm a postdoctoral research at the NIH. And so I've had the opportunity to train many undergraduates that are so excited to go into medicine and apply into medical school. But it seems like so many to actually apply to it, there's so many things you have to be. You have to get certain grades. You have to almost cure cancer at some point to get into medical school. Do you think we should actually be lowering the standards to get into medical school so that we can address these shortages and also provide more diversity in these schools?
No, you can't lower the standards, but that does not conflict with increasing diversity. There are, as a daughter of a science teacher, I can attest that there are brilliant children of every community, of every ethnicity, who would do well in medical school. It's about support, it's about tuition support, it's about supporting careers. I've had lovely conversations with Governor Green of Hawaii about the program that he's doing to be able to forgive loans. So I think we need to be more creative about supporting medicine, but as the person who's lying in the bed, I'm just gonna say, no, we have to keep the standards very high. Medicine is not one where we can lower the standards. What I wanna say about innovation is, though, where I find so many of the energetic med students and fellows and even burnt out physicians are in innovation hubs. And we love working with them on innovative projects of patient-centered research on things like digital pathology to replace biopsy. There's so many wonderful things happening. 3D printing of organs. We're about to change paradigms in terms of tolerance of immunosuppressants. So maybe you don't need immunosuppressants like I do. So there's so many exciting things going on. I wouldn't want anybody to miss it, but you do have to do all the work to get here, but we'll support you through it.
Anyone else have a question from the audience?
Thank you guys so much. And I totally agree about the importance of increasing diversity in medicine. I plan on going to medicine. I just graduated from undergrad. My question relates to sort of the liver a little bit, but I think anyone can answer it. I actually did research in liver regeneration. And something that I saw pretty often is that because the etiologies of liver disease relate to some lifestyle choices, whether that be the use of syringes or the use of alcohol, a lot of the conversation is normative in that you did something that I wouldn't do, something bad, and so you have this disease. And then that's why we see a lot of inequity, because we don't feel called to act when someone's behavior seems like it contributed to the disease. So my question is, as physicians or policymakers or just people who are interested in health in general, what can we do to sort of change the conversation to be less judgmental and less normative, so that there is sort of an incentive to make great strides in health equity?
Well, I'll volunteer to take all of the celebrities that were in that Creative Coalition ad earlier to do a liver campaign. I think that would help. But you're absolutely right. I think there is a false narrative that all liver conditions come from alcohol or something self-induced. And that's not true. There are more than 100 different types of liver diseases. My transplant was caused by an autoimmune disease that started when I was in 8th grade. And so I think that narrative needs to get out. And stigma is the biggest issue that keeps us from being in policies, in conversation, of people valuing us and caring about us. And so we confront it head on by having people meet our patients and actually learn about the science. And so I accept your volunteering with our organization, the Global Liver Institute, and we'll follow up with you afterwards. But I enlist all of you to help us change the narrative. All of you know someone who, well, all of you have a liver. So all of you are at risk of some form of liver disease. And so whether it's a child with biliary atresia or a young person with an autoimmune disease or a veteran with hepatitis C or a grandparent with liver cancer, we can't meet our goals of the cancer moonshot without solving liver cancer. All of you have a role to play.
Yeah. Well, we've run out of time. Great discussion. Please thank our panel.
Thank you again to our panel. The Hill would like to note the PAN Foundation is a sponsor of today's program, but this interview was editorial in nature and produced by the Hill's newsroom. Please welcome Nicolette Lewis-Saint, Senior Vice President of Policy and Strategic Planning at the Healthcare Distribution Alliance, and Sarah Wells-Kosi, the Director of the Center for Public Health at the Milken Institute, for a sponsor perspective presented by the Healthcare Distribution Alliance.
Good morning. It's great to be here and see so many of you in the audience and online. Nicolette, I'd like to start by talking about how we met. We met during the very early days of the COVID-19 pandemic. At that time, you were the executive director of Healthcare Ready, and you were literally working at the nexus of public and private sectors with a focus on ensuring that people had access to medicines during emergencies. Today, you're heading up policy and strategic planning at the Healthcare Distribution Alliance. So I'd like to start the conversation today with you talking a little bit about who HDA is and how they impact patients' lives. And the reason that I want you to start there is because I think that when people think about healthcare in the traditional sense, they think of doctors, hospitals, clinics, and there are distributors that are really critical to the healthcare ecosystem, but they operate largely behind the scenes. So if you could also talk a little bit about who are distributors, what are their role, and what do they do every day for patients?
Absolutely. Thank you, Sarah, and thank you to the organizers. HDA is so pleased to sponsor this event. So yeah, you're right. When we first met, I think it was behind a Zoom screen talking about responding to COVID and the importance of partnerships. So in some ways, a bit of a transition, but in a lot of ways, just continuing that theme. I'm really proud to work for HDA because HDA is a national organization that represents healthcare distributors. And to your point, that is not a part of the healthcare ecosystem that we talk about day in and day out. But healthcare distributors do the work of ensuring that more than 11 million medicines, medical products are delivered to facilities every day. So as I think I mentioned in our first conversation and would bring up here, when we think about what healthcare delivery looks like, we think about the facilities, but without the staff, without the stuff, without the supplies, it's a building. And so what healthcare distributors do is to make sure that those more than 300,000 facilities that depend on having medicines and medical supplies every day have those supplies when they need them on time. And because of the work of distributors, we really focus on operational efficiency. How do we consolidate the process of getting more than 1,400 manufacturers to get those products to those facilities every day? So they're the logistics experts. They're the folks that are thinking about everything from how the product is safely and securely delivered to how to make sure that the roads that may be closed don't create a delay in the delivery.
Thank you. So in my role at the Milken Institute, I work in our Center for Public Health. I've had this great fortune to work with HDA and you over the past year, and it's been really incredible. We studied how the pharmaceutical supply chain supports public health broadly, both during emergencies and non-emergencies. Now, we did a ton of research. There was a lot of key insights and recommendations that came out of a report that was released this spring. But we ended up focusing on 3 key areas: health equity, trust and communication, and public and private partnerships. From all of that work, what stood out to you in what we heard?
So I thought this project that we did was really important because it really was the first time that we looked at the relationship between the pharmaceutical supply chain and the community. Oftentimes we think about the supply chain kind of ending with the facility, but this was where we said, no, it's provider to patient, and with this patient is a part of a community. And what is our relationship there? And so when we were thinking about those 3 themes, I think what really jumped out to me was the fact that when you think about the 3 themes, they're so interrelated. And in some ways, the partnerships, the trust and communication, these are things we've been talking about for a while. I'm really thrilled to continue to see equity be such a big part of the national discourse around healthcare delivery. But they are so connected, and when we are thinking about how we actually advance resilience, a lot of times we're forgetting that piece, that last mile to the community. And so what really stuck out to me in just in the discussions, the research, as well as the report, was the fact that we were thinking about themes that have been discussed previously, but in really new ways. We're thinking about public-private partnerships that were not about community to community, like not about the local health department making sure that this church was a part of the discussion, but really how do healthcare distributors, how do pharmacists have those conversations with those anchor institutions? We were upending the idea that an anchor institution has to be a facility that, a major health system or a large institution. It was really the idea that an anchor institution could be the grandma in the community that everybody listens to because they know if they don't listen to her, it's going to be a problem. And that, I think, was a really important piece of this because we were showing how so many of those connections were the difference in people getting vaccinated or not, or knowing where to go for a vaccine or a COVID therapeutic. So for me, it feels like the start of a conversation. And I hope that as we settle into, whatever this post-COVID world looks like, we are able to actually take those learnings and think about how they help us to be better for the next phase.
Well, let's talk a little bit more about that. I think we are in the post-pandemic landscape now. And so I would really love for you to talk a little bit about how the supply chain is adapting to this short-term kind of aftermath, especially with the public health emergency unwinding. The declaration expired on May 11th. How are things going?
They're still going. And I think that's the beauty of what the supply chain does. We are still continuing to deliver COVID vaccines and therapeutics to facilities. We're still making sure that we are not losing the lessons that we've learned over the last few years. And we're tracking the flexibilities, things like telehealth flexibilities that have been extended, and what that means for not just what product is going to be needed, but where it's going to be needed. But the work continues, and for us, we're at the point where we're starting to think not just about, what happens with the public health emergency transition, but how do we make sure that everything that we've learned and all of these different elements of the different phases of the COVID pandemic translate into what we need to do next to prepare for the next crisis.
Great. Well, I know you focus a lot on policy. And so we can't just focus on the short term. We have to look at the long-term view. So what are your thoughts in terms of what is needed in the policy realm in order to ensure that we have a resilient supply chain going forward?
So I think to start, we really have to make sure that the legislation that is in place, or the must-pass legislation that has to be done within this Congress, gets done. So for starters, we have the Pandemic All Hazards and Preparedness Act, which is must-pass legislation that does a really important job of making sure that the infrastructure that needs to be in place for us to be able not just to respond to emergencies, but also to prepare for them and to make sure that the different components and authorities that are necessary within the federal agencies are very clear so that we are doing that work on a continual basis. That reauthorization is critical in our minds. Part of what we are thinking about is making sure that this reauthorization, so the last reauthorization happened right before COVID. So what this can't be is just everything we've learned from COVID and forgetting, all of the other threats, all of the other risks that we have to manage. But what it should be is an opportunity for us to say, what did we learn here? What really worked? What were missed opportunities? How can we improve? But how do we really stay focused on the elements of supply chain resilience that need to be in this legislation to make sure that we're not putting ourselves at a deficit for the next thing that's coming, because certainly there will be something else.
Okay. So last question. I think it's obvious that the healthcare supply chain is tested every single day. In the past year, we've unfortunately seen some shortages of critical medicines. Last autumn, we saw shortages in children's antibiotics, for example. In recent months, there's been some shortages for oncology treatments for cancer patients. Can you explain to all of us, what's going on here, and where does your organization and your sector fit into all of this?
Sure. So as quickly as I can. Okay. So there are a lot of things going on. To put it one way, if you've seen one shortage, you've seen one shortage. So the different elements that may be the drivers of those shortages, we have to be careful to not put a broad stroke and say, they're all caused by the same phenomena. But part of what we are seeing is that there is a supply set of drivers that may mean that we have to look at how we're thinking about resilient manufacturing, or thinking about how we are thinking about diversification of the supply. But there's also a demand side that we have to also think about, which is what happens when there's a sudden surge. We think about it as medical surge and thinking about a sudden surge and saying whether it's a celebrity saying, hey, use this product, or a legitimate medical surge related to, in December we saw the RSV flu COVID surge. But there are multiple drivers. Part of what distributors do are to track those patterns. Part of where we are really interested in partnering is to think about public health surveillance as an opportunity to be able to see when those spikes might happen and be able to plan and react more rapidly. But also part of our strategy is ensuring that the product that is on hand is allocated in a manner that ensures that there's equitable distribution. And so what that means to us is that we have to make sure that it's not just about who can get the most product, but who needs product, and how do we make sure that those shortages are not creating negative health outcomes.
Well, thank you.
Thank
I
you.
can feel your passion. You're a wonderful leader. It's very refreshing. So thank you so much for your insights and perspectives.
Thank you for having me.
Welcome Dawn O'Connell, the Assistant Secretary for Preparedness and Response at Health and Human Services, to the stage.
Dawn, thanks for joining us this morning. Okay, the pandemic is officially over. What were the lessons learned, and how do you see the future? Because another one's going to come down the road, hopefully not in our lifetime. Right. But what did the government learn? What did your agency learn, and where do we go from here?
Bob, that's a big question, and I appreciate it because we've been thinking an awful lot about it. But first, let me say how grateful I am to be here. Any opportunity I have to talk about the work that we're doing is a good morning for me. So thanks. Thanks for having me and for having such a useful series of panels and discussions. So we've learned a lot. We're not the same, and we're not going to be the same coming out of this pandemic. When I think about the ASPR team and all the work that they've done 24/7 around the clock on behalf of the country to get us the vaccines, the therapies, the diagnostics, the supplies that we didn't initially have in the Strategic National Stockpile, to get it restocked, to make sure that we have domestic manufacturing of these supplies moving forward. Yeah, I'm so proud of all that we've done, but there were things that we didn't have that we needed, that I now know and am asking for. They include some authorities that had us rely on, and we were so grateful for the partnership, but we had to rely on DoD to do our assisted acquisitions. We weren't able to contract as quickly as we needed to get those vaccine candidates, those 6 initial companies that we were working with. We couldn't get them under contract fast enough. And DoD came in with a certain set of authorities that they had and were able to move our contracts much quicker. Well, I'm now asking Congress for those authorities. I won't always be able to rely on DoD, so I think it'll be really helpful if Congress would consider giving that to us, so I can move out. DoD, when it's a whole of government response, is there. Let me be clear: we can all rely on DoD always. Sure. But we need to be able to do the health things so DoD can do the military things, and I think that's just critically important. We also weren't able to staff up as fast as we needed to. We had to rely on FEMA and the Coast Guard, those that had surge hiring authorities and were able to bring people on super fast. We've since been able to staff up, and it's been really helpful to have some of the authorities that were given to us through the supplemental funds, but those are going away now. I think everyone's aware of that, and I'm going to need those moving forward for whatever comes next, hopefully not in our lifetime, Bob, as you mentioned, but I'm going to need to be able to move quickly. We're living in an era of poly-crisis. I can't always have FEMA available. They're going to be out doing wildfires and, and other weather events as we're seeing climate change pick up. I'm going to need to be able to do the health things, so I'm asking Congress to help me do the health things better, faster, moving forward.
There are a lot of people asking Congress for a lot of things now. Where do we stand on you getting that authority?
Well, I've had the opportunity, and I do call it an opportunity, to testify 13 times in front of Congress, just in the 2 years that I've had this job. And each time I go up there, I try to make sure they know how important the work that ASPR is doing is and how critical the teams are, but how we did need help and we didn't have everything we needed at the start, and how fast, how much more we could do, how much faster we could go if we had these authorities. I continue to be optimistic that they're currently doing the Pandemics and All Hazards Preparedness Reauthorization. That was our authorizing bill back in 2006 after Hurricane Katrina. They set up our office. So we continue to look to them every few years to reauthorize those authorities. And I've asked that to be the vehicle that we use to get these additional hiring and acquisitions authorities that I'm seeking coming out of the pandemic. And they're working on it, and they have heard me, and we've had wonderful conversations with several members. So I remain optimistic.
And who are the main players? Because it's a bipartisan initiative.
It's a bipartisan.
It's going to have to be, right?
Absolutely. So we've got strong leadership in the House on the Energy and Commerce Committee. Both sides of the aisle have been working very closely. Each have designated their lead interlocutor, and we've been working very closely with those offices. Same with the Help Committee. Chairman Sanders has deputized Senator Casey and Senators Romney to work on this. And so we continue to engage and remain available for any technical assistance Congress is looking for to understand exactly why it is we need these authorities moving forward.
And is the timeline the end of the fiscal year that this needs to get done?
That's right.
Okay. And do you think it could get done by then? That's your hope. But obviously, if not, then Congress punts sometimes if they don't have time. We've seen that many times.
Absolutely. We remain optimistic that they'll get it done in time, and we'll continue to engage until it's finished.
Okay. We were talking earlier about drug shortages. Where are we on drug shortages in this country?
Well, I think everyone, if you've been reading the news, you've seen that we have significant drug shortages, which are a big worry for those of us part of the HHS family. The place where ASPR, my organization, plays, we've been able to onshore some critical API. That was one of the things that we were able to do with supplemental funds from COVID. So we've got about $500 million invested in bringing that capacity onshore, but that doesn't solve the larger problem. So we work very closely with FDA. FDA is the organization that the manufacturers work with within HHS when they need to identify that there's a shortage. And we would need additional funds, frankly, if the $500 million that we've invested gets us started on the API that we need in the response framework, for BARDA and other critical medical supplies in times of a crisis. But that doesn't cover oncology. That doesn't cover, general pediatric. There are other places where there are shortages that are being felt that will need to get picked up and answered with additional funding in a new way.
I know we talked about the reauthorization and Congress's role, but can you tell us a little bit more about the reorganization that you've done at ASPR and what it means for patients, how it improves? Because there are a lot of health agencies, and it's very confusing to average consumers.
Well, I really appreciate that question because I'm afraid not everybody understands what we do. And so any opportunity I have, Bob, really to talk about ASPR and the good work of the teams, I take advantage of immediately. So we're the Administration for Strategic Preparedness and Response. We were founded in 2005 after Hurricane Katrina with that 2006 PAPA bill. And we were founded initially as a staff division. And this is a little bit of inside baseball, but we were founded as an office in the Secretary. One of my principal jobs and statutory jobs is to coordinate the department and to be the principal advisor to the Secretary on public health emergency response. So we were initially put in as an extension of his office, and we have operated in that way up until last summer. Even though we were very operational in a lot of ways, we did not serve as a standalone agency like CDC, like FDA, like NIH. We were part of the Office of the Secretary. But realizing how operational we've always been, but how much more operational we've become, how many national programs we run, we needed some independence in order to be able to build the HR capacity that an organization that's under the amount of stress that we are under to respond immediately to public health emergencies. We needed to build our own HR capacity and not just attach to the capacity that was part of the Secretary's office. We needed our own acquisitions capacity. Now, this is the infrastructure. This is the support that we need in order, should we get the authorities we're asking for, to operationalize those authorities. And being a standalone agency within HHS gives us that independence to build like CDC, like FDA, like NIH. And we have a national disaster medical system. We've got teams of clinicians that go out and respond to whatever public health emergencies come out of any disaster. We have the Strategic National Stockpile. I think everyone learned about the Strategic National Stockpile in March 2020 when we opened it up to see what was in it and didn't have the things we need. Well, we've been restocking that as we go. We have BARDA, which is the Biomedical Advanced Research and Development Authority. They're responsible for doing the late-stage development of the countermeasures that we all have relied on these last 3 years, the vaccines, the therapies. And we now have our supply chain work, the industrial base expansion effort to bring in domestic manufacturing of these critical medical supplies. All of those are operational responsibilities that we have. Just to say, the Secretary made us an operating division or a standalone agency when he saw the breadth of everything that we had taken on in COVID. And this gave us the ability to begin to build out the capacity that we need to move forward faster next time. I've also reorged. So when I got into the organization, I came in and was looking for that strategic national stockpile, that thing that captured everybody's attention in early 2020. I couldn't find it on the org chart. I had to look 3 levels down for something as critically important as the Strategic National Stockpile. It did not report directly to me. Well, we did a reorg, which we were able to roll out in January of this year, in which the Strategic National Stockpile, which is the single largest line item I have in my budget, is now an independent office within ASPR that reports directly to me. I needed to have that accountability for something as critical as that is, as well as the increased visibility into the work that they were doing. So that's an example of some of the changes I've been able to make on my own. The authorities I'll need help from with Congress as we continue this transformation.
Something that has faded from the headlines, but I did want to ask you about Mpox, and where are we as far as, are you concerned about that coming up again? Where are we in the treatment of it?
So Mpox was one of those things that we were watching this time last year and actually doing significant amount of response work. We were lucky that within the Strategic National Stockpile, we had a small stockpile of a smallpox vaccine that we had purchased for the immunocompromised. It turned out that smallpox vaccine also was licensed by FDA for use in Mpox. And at the time, Mpox was something that we were seeing in other parts of the world, but hadn't really spread widely the way we saw it spread last summer. But as soon as we began to see the way it was spreading, and it was spreading differently through close, intimate contact last summer, we began to look at what we had and make it available, anticipating that it was going to come to the United States. And of course it did, and it came quick. And it was this time of year, June, July, and August, when we really saw the uptick in cases. As we moved out of the summer months, and we deployed on a national level this vaccine, we began to see the case counts go down. In fact, through much of the winter, there were 1 or 2 cases every now and again. But now that we're hitting the summer months again, more activity, more people are out and about, interacting with each other. We are seeing a small cluster in Chicago, and are continuing to watch that very closely. You'll see lots of effort to get the vaccine back out this summer and get ahead of what could be a potential outbreak. But so far, outside of what we're seeing in Chicago, we are very vigilant, but not seeing major worry.
Can you take us behind the scenes about how the government, HHS, ASPR, all these government agencies work to keep track? You mentioned Mpox in Chicago. How do you track all that? Obviously, the coronavirus started in China, but so this is a global. What are the methods to finding out information?
Well, there are a couple of things. We work very closely with CDC, and one of the things I think people don't understand is where we begin and where they end. And so they have the surveillance apparatus in place, the relationships, as do most of us in the department, but close relationships with international colleagues. And so as we're seeing things show up globally, that gets plugged into the CDC forecasting system and their modeling system, and they are watching surveillance. And we rely in ASPR, so this is where we sort of begin and end. So CDC has this data, they do the forecasting, they do the surveillance. When they see a signal, I have the tools in ASPR. So right now, Dr. Walensky and I would look across the table at each other and say, okay, we're seeing this signal for Mpox. Okay. What do we have for vaccines, for therapies? We know we can anticipate we're gonna need vaccines, therapeutics, diagnostics, for most any outbreak that we see nowadays. So I lock in with CDC, see where it is. They have the epidemiological expertise. They're going to tell me how severe it is, where they imagine spread is going to go. I deliver the tools to those places, and together we mount this response.
Looking forward over the next year, 5 years, what are you most concerned about?
Well, there are a couple of things. This is a great question. And I spend my nights up so you guys can sleep well, I hope. We worry about a lot. We're seeing, I mentioned polycrisis. We're seeing things happen, not one wildfire at a time or one tornado or hurricane at a time, but having them happen at the same time, simultaneously. Do we have enough staff to be able to keep a response going on a multi-front? And people may not realize, throughout COVID, we were continuing to respond to various disasters and public health emergencies. While we were doing COVID and running, that 3-year acute response, we were also, like last summer, had our largest hurricane deployment after Hurricane Ian in Florida. We also were watching very closely the Marburg outbreak right now, but in Tanzania and in Equatorial Guinea, and wondering if our investigational vaccines and therapeutics needed to be deployed there. We did deploy some to Uganda for the Ebola Sudan response that they had. So we continue to do all of this, but I worry that as these are multiplying, as they're becoming more severe, do we have enough? The other thing I worry about is that thing that we didn't expect. If we were sitting here in 2018, everyone would have said the next big thing is going to be a highly virulent flu. and we would have all been preparing for what that would mean. Well, we were right, it was a respiratory illness, but it was a coronavirus. And while we were all thinking about what it would mean to be ready for a pan flu outbreak, which would be extraordinarily severe, Corona came in the, in the living room window while we had the front and back door locked. Are we looking at those things? Are we not just preparing for what happened, but for what could happen? And BARDA has taken on a threat agnostic approach. They're really looking not at one bug, one drug anymore, but they're looking at solving, the symptomatic responses to any threat that could come. And I think that will give us a few more tools that we need to respond to those things that we don't expect.
Last question, because it's now something more of a new phenomenon, as we talked with Dr. Fauci, misinformation. How do you deal with that?
Well, that is a challenge, and it's something that we continue to wrestle with within HHS and, of course, across this administration. One of the things that we do at ASPR is make sure that we, model correct and appropriate behavior and make sure that we are not giving any, just any opportunity for anyone to question the decisions that we're making. We try to be very transparent about why we were making a decision, what we know, what we don't know, what we're doing, what we expect you to do, and that could change depending on the science as it comes in. So we've just tried to be very transparent, but it is a problem, and it's something that we're all going to have to wrestle with.
Absolutely, and also the role of the media as well. Yeah. Dawn O'Connell, thanks for joining us. Really appreciate it. Thank you. Thank you so much.
Now, joining us to talk about building an equitable and healthy nation is Dr. Jerome Adams, former Surgeon General.
Hey, Dr. Adams, how are you?
You are the hardest working man in D.C. today. I'll tell you what.
Yeah, up early, but we have a great staff. I'm just a prop, as I say. So you were at an event a while back, I can't remember exactly when, and there's a lot has happened since then. I want to start out with a big, vague question, because I know your wife has had some issues. We've also had some issues with you working for the Trump administration. But first, I want to say, what were the takeaways and what surprised you during your time as Surgeon General?
Oh, my goodness. Well, first of all, and this is self-promoting, I have a book coming out in November called Crisis and Chaos, and I talk about a lot of the lessons learned because we won't be able to cover them in 15 minutes. But I hit some high points.
I like that title. It's very catchy.
Well, that's what the publisher said. I wanted to call it something different, okay. But they wanted to make it attractive. But a couple of quick points that we cover in the book and that I think people don't always appreciate. Number one, you can't make good decisions if you don't have good information. And there's a lot to unpack there, but all the way back in the beginning, and Tony talked about this earlier, we weren't getting good and transparent information from China. So a lot of our early decisions were based on what we thought the coronavirus would do versus, excuse me, what it was actually doing on the ground. We also, and we just got to own this, we didn't do a good enough job standing up testing. Other countries beat us to testing, and so we did not know what we didn't know because we couldn't track testing. We couldn't see the virus. And I would argue to this day, we still don't have a good testing policy. We don't know what we don't know because we've essentially stopped testing. One of the biggest surges under the current administration was during the Delta wave when the administration didn't test. So important to know that we can't make good decisions if we don't have good information. And then finally, with the ending of the public health emergency, and I had an op-ed about this, CDC lost a lot of their reporting authorities. And so we weren't getting the information that we needed. That's number one. Number two, COVID is not the problem. COVID was just a magnifying glass on the problems that have existed for decades, for centuries, health inequities. The same people who are predisposed to dying from COVID are the ones that are predisposed to dying from liver disease, from cancer, from opioid overdoses, from infant and maternal mortality. It was a magnifying glass. It was a magnifying glass on vaccine hesitancy. It was a magnifying glass on misinformation. It wasn't the problem. And if we really look at COVID as a fire to be put out and say, okay, COVID's done, let's move on, then shame on us. So that's number two. And then the final point that I would make that I don't think people appreciate. We were sold on this idea in 2020 that if you just changed the person who was at the captain of the Titanic, we weren't going to hit the iceberg. The truth is that factually, more people died in 2021 than in 2020. We had more infections. We saw more of the same in terms of policies. The tone did change from administration to administration, but the outcomes didn't. And this is not me saying shame on the Biden administration or casting aspersions on them. It's saying that if we make everything about Trump and we make everything about one administration versus the other, then we're missing the broader point and we're setting ourselves up to fall victim to the same challenges over and over and over. And you saw this with MPOX. We should have hit MPOX out of the park. We absolutely should have hit MPOX out of the park because we were in batting practice for 2 years. And we made the exact same mistakes over again with MPOX in terms of poor communication, in terms of not standing up testing, in terms of not being able to distribute vaccines and treatments to people. So it just shows that we aren't learning the lessons because we always want to say it's Trump's fault, it's Biden's fault, instead of looking at the underlying issues.
You mentioned Trump, and you've said publicly that, as you know, Donald Trump is running for president again, that him running again in the 2024 campaign is going to make your life harder. Why?
Well, so what's interesting is if you go all the way back to 2019, the head of CBS famously said, Donald Trump is bad for America, but he's great for CBS. He said that. You can look it up. The media is addicted to talking about Donald Trump because it is good for them. How it impacts me. I can't do a news story to anywhere without them putting as the headline, Donald Trump's Surgeon General says. It's not a health story, it then becomes a political story. And that's me, but it's impacting our ability to have rational conversations about important issues that, again, are about so much more than Donald Trump. And that's really the point I make in my book. I literally say in the beginning of the book, this book is not about Donald Trump. And many people wonder why it took so long for the book to come out. No publishing company wanted to publish it because they wanted a book that was all about everything Donald Trump did wrong. I mean, and that's the challenge that we continue to have, and again, that sets us up for the same thing all over again.
Your wife has battled melanoma. Can you update us on that? Another thing you've talked publicly about, what did you learn from that battle, which has been ongoing?
Well, what's interesting is during the pandemic, for many of you all, for many people, I was a figurehead on TV. But I was the first Surgeon General in modern times to have school-age kids. So I was literally dealing with homeschooling and trying to figure out, do we have enough broadband access, bandwidth? Do we have enough computers? Can we put the kids in different places so they can learn? I understood this in a way that a lot of, quite frankly, our decision makers didn't. And I was one of the earliest people to say, hey, we got to figure out how to get these kids back in schools, and/or we have to give people the resources to be able to adequately do homeschooling. So I mentioned that because we started talking about family. But my wife, many of you know, has stage 4 melanoma. And she had a recurrence during the pandemic. And we won't know, we'll never know to what extent the pandemic impacted her, but I know that her PET scan was delayed because of the pandemic. We know that it made it difficult for her to go in and get treatment during the pandemic. So again, these concerns that people raise about pandemic policies impacting broader health issues are valid, and I understood them in a very personal way. My brother, who I've also talked about, while I was standing in the White House next to the President of the United States, he was sitting in a prison cell about 25 miles away in Jessup, Maryland, due to crimes he'd committed to support his addiction. They actually released him during COVID because a lot of people got released, but then he couldn't get treatment. And so in a very real and tangible way, I understand the frustration that many people have when they hear and perceive themselves to be at low risk for COVID, but see very real health issues popping up, mental health and physical health issues popping up in their communities and their friends and their family related to their inability to access care because of COVID policies.
Why is there any, what is the solution? And I know it's not going to be done tomorrow, but healthcare is so polarizing. We're living in such polarizing times. It's not like nothing gets done on Capitol Hill. The Cancer Cures Act was passed a while back, and there has been bipartisan healthcare legislation, but it's harder to move. How do we, we were talking about the protesters outside for Dr. Fauci, when is this going to change? Can it change? How can it change?
It can change, and it has to change, and let me tell you why it has to change and why it will change. I've talked to health economists, and healthcare being 20% of our GDP is about the breaking point. At some point, you can no longer continue to grow an economy when healthcare is 20% of your GDP, because that means a lot of your people are getting sick. Your workforce is getting sick. And one of the things we were talking about in the green room is one of the rare places you can get bipartisan agreement now is around the workforce crisis that we have in our country. Why do we have a workforce crisis? Too many people have checked out because of the opioid epidemic. Too many people are checking out early on in their 60s and even now in their 50s because of multiple chronic diseases. Too many people are checking out because of long COVID. This is no longer a health crisis and an individual problem. This is a societal problem. So I actually saw this coming, and when I was Surgeon General, before the pandemic, I wrote a report along with the Chamber of Commerce, the UVA Darden School of Business, and others that was unlike any report a Surgeon General had ever put out. Why? Because it wasn't written for a health audience, it was written for a business audience. It was called Community Health and Economic Prosperity, and it was making the case that health matters to our economic success in this nation, and that businesses have to lean in. And to get to the point, I think the way this changes is when you have Jeff Bezos, when you have Elon Musk, when you have Mark Zuckerberg saying we need to have more inclusive workplace policies, we need to have paid time off, we need to have flexible work schedules, we need to build healthier communities because it actually helps us retain and recruit and retain employees. It lowers our healthcare costs. Do you know that for Fortune 500 companies, the number 2 expense that they bear is healthcare? Again, it is not sustainable, and the business community is starting to wake up to that fact. They're locating their companies in states that have higher health or better health outcomes intentionally because they want that number 2 cost to be lower. And states are starting to see that, and they're starting again to build healthier communities. I think that's going to be the nidus for change. It's not going to be an individual, hey, this is the right moral thing to do. It's going to be a, hey, we can no longer remain successful as an economic entity if we don't pay attention to health.
Tell me about writing the book. I know you mentioned that it wasn't accepted by some publishers at first, but was it cathartic?
It really was. So what's interesting is I got to see everyone else's books come out. Deb Burke's book, Scott Gottlieb's book, Brett Giroir's book. They're all friends, and they all sent me signed copies, and I go through and I see the different narratives. For me, my book is part memoir. And when I say part memoir, I was just the second African-American male Surgeon General in history. That was pretty significant, pretty historic. And it's interesting because so many people said, why did you stay? How could you work for that administration or that man? Why didn't you leave? As the second African-American male Surgeon General in a community, and you heard on the last panel where we have fewer black males graduating from medical school now than we had 40 years ago, you ask me, how could I stay? How could I not? How could I not stay? How could I not take advantage of that opportunity? And I would argue when you disagree with an administration, that's when it's even more important that you have people at the table who look like you, who think like you, who can speak up to your issues. And that's a lot of what I actually did on the COVID task force. So this is what it's like for my wife at home trying to raise kids. This is what it's like for my brother who's incarcerated. This is what it's like for populations who aren't always heard. There's a saying, if you're not at the table, you're on the menu. I wanted to be there, and that book talks about being at the table and the real challenges of being at the table. It was hard. It was hard because I was getting beat up by the very people who I was at the table trying to support and trying to fight for. I also give you some perspective about what was happening, but I don't do it from the standpoint of absolving myself from blame. We all have plenty of blame to share in this, but I try to give people some insights that will help us avoid these problems in the future. And one of the insights, for instance, is that I'm a doctor. When you ask me to explain something, I'm used to getting behind a podium and pulling out my 50-slide PowerPoint presentation and walking you through the nuances. That's a very different environment than when you're going on CNN with Jake Tapper and he says, Donald Trump forgoes mask. He's going to have a big rally and our experts say it's going to kill thousands. coming up next, Donald Trump, Surgeon General, to explain. And that's literally how my media interviews would go. And the point I'm making is that we need to prepare health professionals for an environment where that's the type of discourse that you're having. We need them to prepare to be on Twitter and TikTok. I have a very robust Twitter presence, as many of you all know. And I think it's important because most people, health professionals included, say they get the majority of their health information online. So if we're not there and we don't know how to be effective in that space, we're going to get our lunch handed to us by Joe Rogan over and over and over again. And so I talk about that. But I also, again, try to make it very practical and say, here are the lessons learned from, again, the lack of information to how we engage with the media, to our failure to pay attention to health inequities, to challenges about trade-offs when you look at schools. You can't run a school without teachers and bus drivers. So what are the rights of the students to be at school versus the rights of those teachers and bus drivers and cafeteria workers to be safe? We talk about these things in a way that is much more nuanced than, again, 3 minutes on CNN or 3 minutes on Fox News.
Last question, a lot of healthcare stakeholders in the room, also watching online. What would be your advice to them to make the healthcare system better?
My advice, number one, would be healthcare is not health. Only about 80% of only about 20% of your health is determined by your access to health care. So we need to think outside the box. We need to think about our built environment. We need to think about houses people live in. We need to think about the parks and green spaces that exist around individuals. We're here talking about diabetes and obesity, and I love talking about my daughter, and I promise I won't drone on, but my daughter spends a little bit too much time on TikTok. And when she does, I say, Millie, give me your phone, go outside, I don't want to see you for an hour. She's 13 years old. I can do that, and that makes me a good dad because she's out getting fresh air, she's getting exercise, but I live in a nice neighborhood. We have complete streets, full sidewalks, all the neighbors know her, there aren't drug dealers in my community. Different dad, 6 miles south of me on the east side of Indianapolis, tells his 13-year-old daughter, give me your phone, I don't want to see you for an hour. That's criminal child neglect. And so it's not about whether I love my daughter more than he loves his daughter. It's about the environment that determines people's choices and their outcomes. And so if we want to change health outcomes, we can't keep focusing and doubling down on the 20%. I love Ozempic. I agree that we need to make it more available to more people, but we're not going to solve the problem with Ozempic. Finish with another story about my kids. My 2 boys, they're 17 months apart, and they were living terrors for most of our parenting lives. They're now 18 and 17, and they're now terrors in a very different way because they're both driving. But yeah. I came home from work one day, and there was water coming out of the chandelier in our dining room. So I run upstairs.
Out of the chandelier?
Out of the chandelier.
Okay.
So I run upstairs, and the boys had flooded our bathroom. And so I see water coming out of the bathroom, going to the wall, and going down, towards where I can see that the chandelier is. So my first instinct is to grab a towel. And I grab a towel out of our closet, throw a towel down. Towel quickly gets soaked up. Grab another towel. Grab another towel. Pretty soon, all the towels are on the floor. The water's still coming. What's the problem? I've got to figure out where that water is coming from and turn off the spigot. Well, the problem with our health care system is we're throwing towels at the problem with Ozempic and with naloxone and with all these things that are important, but aren't going to actually help us turn the water off. We need to get upstream and build healthier communities, address social drivers, and we need the business community to understand they have a stake in this because they're going to be able to influence Congress's policies way more. Congress doesn't care when the Surgeon General comes. They don't, and says we need X, Y, or Z. They care, like I said, when Elon Musk or Jeff Bezos comes and says we need to do this. So I would rather have those two out there arguing for higher taxes on smoking, for more inclusive communities, than to have, again, the Surgeon General or the HHS Secretary or anyone else out there. So I think that's how we change the healthcare system, is get it focused more on upstream prevention. I love that you had a discussion about value-based purchasing earlier. W. Edwards Deming famously said, every system is perfectly designed to get exactly the results that it gets. Our system rewards sick care. And I say we don't have a health care system. What we have is a sick reimbursement system. Our system rewards people getting sick instead of rewarding them for getting healthy. We need to change the way we pay for healthcare so that we can focus more on upstream prevention, and we need to get more people, including the business and the military community, and you heard this earlier, 71% of 18 to 24-year-olds in this country are ineligible to serve in the military right now. This is a national security imperative. I would rather have the head of the Army going out there arguing for healthier communities than to have the Surgeon General of the United States. When we can create that inclusive and a holistic idea of health and not just focus on health care and downstream Band-Aids and throwing towels on the water coming out of the chandelier, we will be in a much better place moving forward.
Dr. Adams, thank you so much for joining us. Please thank Dr. Adams.
Is my QR code, it's called Crisis and Chaos. Please check it out. I took pains, again, not to make this a political book or a book that's about, hey, I didn't do anything wrong. I really think we need to reflect on again, what COVID taught us. The greatest health advances in history in our country have come not during times of calm, but during times of crisis. And shame on us if we don't use and leverage this crisis to actually reflect on the root issues and create a better society for everyone moving forward.
Well said.
Thanks, Bob.
Dr. Adams, thank you so much.
Thank you, Dr. Adams, our moderators, and all of the amazing guests who joined us today. That brings us to the end of our program. On the behalf of The Hill and our sponsors, Novo Nordisk, Consumers for Quality Care, the Healthcare Distribution Alliance, and the PAN Foundation, we would like to thank everyone who joined us here today, and for those of you who tuned in online. If you missed any portion of today's discussion, the full event video will be available on thehill.com shortly. Thank you very much. Our friends at the Press Club have asked that we clear this room by 11:30, so if you'd like to continue networking or discussing with your colleagues, please step out back. Thank you.